Yeah,
Okay. So, first of all, I would like to thank Dr. Iyer sir and the organizers for giving me this opportunity. So, my talk would be on salivary gland cytology with histological correlation. So, before starting with the cytology, we'll just discuss the normal anatomy of the salivary gland. So, we know that there are three salivary glands. The largest one is parotid, then we have submandibular and sublingual. Parotid gland is situated just in front of the ear, that is preauricular area, and it has a superficial and deep lobe. And between this superficial and deep lobe, um, there is a facial nerve going through. Okay. Then we have submandibular gland, which is situated below the jaw line, and it also have a superficial and deep lobe. And sublingual glands are situated under the floor of the mouth on the either side of the tongue. So when we talk about sampling techniques of salivary gland lesion, FNAC is the main diagnostic workup for salivary gland lesions. And we use 23 to 25 gauge needle with syringe attached. That is, we do vacuum assisted aspiration. Needle core biopsies are performed, but they are done occasionally, especially when the assays are non-diagnostic. Needle core biopsies, although they provide larger tissue samples and they offer more architectural information than the FNAC, but the complications are very high with these biopsies in terms of facial nerve injury and tumor seeding along the biopsy tract. So indication, we all know if there is a palpable salivary gland lesion or if there is a radiological lesion, then we go for blind FNAC or ultrasound guided FNAC. Now, why there is a need of standardized reporting system? First, we want good communication within the institute among the pathologist, with the clinician, with the patient regarding what we want to convey to them, what is the complete information which we want to give to them. Second, we need our data, our result to be consistent and reliable. Okay. Then third, our whatever we are reporting, it should help the clinician in assessing the risk of malignancy and in treating and in monitoring its patients. Okay. So it should play an important role in the clinical decision making. Then definitely standardized reporting plays an important role in research purpose. And the main role of standardized reporting system is that in those of indeterminate categories where we don't know how to report such unclear or unambiguous findings. So these standardized reporting system, they provide us a clear guidelines on how to go about these cases. Okay. So in salivary gland cytopathology, we have Milan system. So it has given 6 diagnostic categories, and each categories have its own definition and its own associated risk of malignancy. First category is non-diagnostic. Non-diagnostic FNA aspirate is labeled as non-diagnostic when we can't give any cytological diagnosis. And this FNA aspirate is placed in this category only when we have examined the entire material. Second is non-neoplastic. In this category, we place the benign entities, and so usually these specimens are either inflammatory, metaplastic, or shows reactive changes. Third category is ATP of undetermined significance. In this category, we place the FNA aspirate when we are not sure whether this is benign or it is non-neoplastic. Okay, when we are not sure whether it is non-neoplastic or neoplastic, so we place that FNA aspirate in the ATP of undetermined significance. But majority of these FNAs will represent reactive ATP or poorly sampled neoplasm. Then fourth category is neoplasia, which is further divided into two: benign and salivary gland neoplasm of uncertain malignant potential. So in benign, we place those aspirate where we have made the diagnosis on the established cytological criteria. So the classical cases of pleomorphic adenoma, Warthin tumors, oncocytomas, lipomas, they all will be placed in the benign category. In some, we'll place those entities where the diagnosis is not made, where we are not sure ki, okay, we don't know whether this is neoplastic, we know that, but we don't know whether it is a benign or it is a malignant. So majority of aspirate in this category will be of cellular benign neoplasm or neoplasm with atypical features or low grade carcinomas. Then category 5 is suspicious for malignancy. Here the FNA aspirate is showing features which are highly suggestive but they are not unequivocal for malignancy. So the majority of specimen in this category will be high-grade carcinomas. So it is always good to give a differential diagnosis, and if you can further subtype the malignant tumor in this category, then the last category is malignant, where we know that the cytological features are diagnostic for malignancy. So it is in this category, we need to further subtype the malignancy, and also, if possible, give the grade. Okay. So now we have second edition of Milan system. The changes are that they have recalculated the risk of malignancy associated with each diagnostic category. So for non-diagnostic, the ROM has reduced as compared to previous edition, 15%. For non-neoplastic, it more or less same. For ATP of undetermined significance, it has increased to 30%. In neoplasia, category 4 benign, it has reduced to 3%. And for some, it is same, 35%. And for suspicious for malignancy and malignant, the ROM has increased to 83 and 98% respectively. So if we talk about normal salivary gland cytology or histology, we know that salivary gland is made up of secretory units. There are two secretory units of cell, serous and mucinous. Parotid gland is largest, so it is mainly composed of serous unit. Submandibular gland is a mixture of both serous and mucinous, and sublingual is predominantly mucinous. So close to this secretory units, there is an intercalated duct which is lined by a cuboidal lining. Intercalated ducts opens into the striated duct, which is lined by eosinophilic columnar cells, and this striated duct then opens into the excretory duct, which is lined by pseudostratified columnar cells, and finally this excretory duct opens into the stanchion duct. Okay, so if we see cytology, then we see that this acini and the serous, they are arranged in grape-like structures in a acinar pattern, and along with this lobules, there is a ductal component, which is usually in form of sheets or tubules, and these ductal cells, they are small with the scant ill-defined cytoplasm and have round nucleus and fine chromatin. So coming to the cases, this is a 30-year-old female with parotid swelling. The FNA was done and it yielded a scantily cellular smears, and there were few histiocytes and occasional lymphocytes, and the background was proteinaceous. So what can be the, so how should you report this case? So this case was given as non-diagnostic, non-mucinous cyst fluid. Okay. So so it is important when you are giving a category, you should further subtype it. So we have given it as a non-mucinous cyst fluid. So on histology, when we received the histology, it was a unilocular cyst, and which was lined by a stratified squamous epithelial lining, and beneath that lining there was dense chronic lymphoid infiltration with germinal center formation. And so any guesses? What can this be? So this was lymphoepithelial cyst. Okay, and we did Elsin blue pass also, just to see if there's any mucinous areas or not. So when we talk about non-diagnostic category, the cytological criteria for this category is there should be rare or absent cells. If the slides prepared are of poor technical quality, which occlude the evaluation of the cellular component. If there is a presence of non-neoplastic, that is normal salivary gland elements in the setting of clinically or radiologically defined mass. So this is important. If we are seeing if normal salivary gland element and clinically there is no mass, then you don't place this aspirate in non-diagnostic category. You will give it as a non-neoplastic category. Okay, but if there is a clinically or radiologically defined mass, and then also you are getting a normal salivary gland elements, then you will give this as a non-diagnostic. Okay, presence of fibrous stroma alone without any cellular component, because fibrous stroma can be seen both in inflammatory conditions and in neoplastic conditions. So we give it as a non-diagnostic. But if it is a matrix component, then you don't give it as a non-diagnostic. You give this aspirate as a ATP of undetermined significance. Non-mucinous cyst fluid without any epithelial component, again, it will be diagnosed as non-diagnostic. But if this is mucinous cyst fluid, then you'll give it as a AUS. Necrotic debris devoid of any epithelial or inflammatory cells. Again, when you are seeing only necrosis, then it's always good to mention a comment that a clinical radiological correlation is needed, because sometimes the cystic metastasis from squamous cell carcinoma of oral cavity usually present with the necrotic debris only. So it's always good to write comment or note whenever you sign out non-diagnostic category. Okay, next is 21-year-old female with bilateral submandibular swelling. So the aspirates were cellular. We can see that there were sheets of ductal epithelial cells, and these ductal epithelial cells, they were interspersed, impinged by small lymphocytes. And in background, it was mostly fluidic background, and there was no acinar cell seen, no foamy histiocytes, or no lymphohistiocytic clusters, and etc. So this was given as non-neoplastic lymphoepithelial cell adenitis. Because the history was characteristic, it was young female with bilateral submandibular swelling, and the patient also had dry eyes and mouth. So it was fitting the clinical scenario. And on histology, when the specimen we received, we saw that the lobular architecture was maintained, but there was a destruction of the acini by diffuse sheets of mature lymphoid cells. And but these lymphoid cells, they showed reactive pattern on immunohistochemistry for CD3 and CD20. Okay, so when we talk about lymphoid-rich lesions, these are the differentials which should come in our mind. First is chronic cell adenitis. Okay, but if there is a chronic cell adenitis, then the smears will not be this much hypercellular. In chronic cell adenitis, usually you get hypercellular smears, and also the ductal component is in form of small clusters. You don't get such large sheets of ductal epithelial cells. And in background, we'll get chronic inflammation, fibrotic stromal fragments. Second differential can be lymphoepithelial cyst, but again in lymphoepithelial cyst, you'll not get such large sheets of ductal epithelial cells. Also, the background will be proteinaceous, fluidy background. Then there can be tumor-associated lymphoid follicles. But for this, we need a good clinical and radiological history regarding if there is any mass or lesion in the salivary gland. Then metastatic carcinoma to lymph node, again, if there is a metastatic carcinoma, then there will be overtly features of malignancy in form of nuclear pleomorphism, mitosis, and background necrosis. The last differential, extranodal marginal zone lymphoma, is we need to be questioned regarding this differential, because in this there will be monomorphous population of lymphoid cells. So whenever we do FNA, aspirate, and so it's necessary that we make a cell block or we take aspirate for flow cytometry, so that we can do further ancillary studies, okay, to rule out lymphomas or any other differential. Okay, next case is 50-year-old male with parotid swelling. So again, the smears are cellular, and we can see that there is this characteristic chondromyxoid fibrillary stroma, and there are some myopithelial cells which are ovoid to spindle shaped, and in background is hemorrhagic. There is no mucinous background. The stromal fragments are quite cellular, and there is a predominance of spindle shaped cells, but there is no nuclear pleomorphism or mitosis or background necrosis. So definitely this is not malignancy. So it was given as category 4B, some mixed type. Why we gave it some? Because these stromal fragments, they were quite cellular, and there was predominance of spindle cell population. So what is the cytological criteria of pleomorphic adenoma? First, it should have a distinctive fibrillary chondromyxoid matrix, and there should be presence of biphasic cell population comprising of myoepithelial cells and ductal cells. Myoepithelial cells can be of different shapes like polygonal, plasmacytoid, round, spindle, stellate, and clear, but the nuclear features will be bland. And often there will be one single cell type predominant. Ductal epithelial cells, they'll be mostly in form of sheets or tubules or ductules, but they'll also have a bland nuclear feature. So in pleomorphic adenoma, we don't see nuclear pleomorphism, mitosis, or necrosis. And if you do IHC, then you demonstrate the myopathial differentiation and combined with PLAG1 and HMGA2 positivity, which is specific for pleomorphic adenoma. What are the diagnostic pitfalls? And suppose your smear is highly cellular and there is scant or absent matrix. So what all differential you will think of? It can be a solid variant of adenoid cystic carcinoma, myoepithelioma, or any basiloid neoplasm. If there is a thin and mucoid matrix, then you'll think of low-grade mucoepidermoid carcinoma. If there is a predominance of myopathial cells with spindled morphology, you'll think of schwannoma, nodular fasciitis. Sarcomas and spindle cell carcinomas, you will keep it down the differential list, because in these cases, you will see overtly malignant features in form of nuclear pleomorphism and mitosis. So on histology, for this patient, there was the lesion was well circumscribed, and there was classical pleomorphic adenoma areas, but then there was large areas which showed long fascicles intersecting fascicles of spindle-shaped cells, along with myxoid areas, and there was mild nuclear pleomorphism. However, there was no marked nuclear pleomorphism, necrosis, or mitotic figures. So it was a pleomorphic adenoma of spindle type. Okay. So the next case is 25-year-old male with left parotid swelling. Again, these smears are quite cellular, and there's a stromal fragments. These stromal fragments, they somewhat look like chondromyxoid in appearance. Okay. And these cells, so there are large number of singly scattered cells. Individual cells, they appears to be plasmacytoid to spindle shaped, and the stromal fragment is also quite cellular. So based on this morphology, it was given as a neoplasm, benign, that is pleomorphic adenoma. But on finding out the radiological finding, it was on CECT, it was seen that there was a lytic lesion in the upper two-third ramus of the mandible involving the condylar process. And this lytic lesion was infiltrating into the soft tissue, and it was showing sunburst periosteal reaction. So, and according to the clinician, the swelling was quite hard, and they were not suspecting it as a primary salivary gland tumor. So when the core biopsy was received, it showed that there were around two spindle-shaped cells in a fibrous stroma, and these cells, they were positive for SATB2. So it was basically osteosarcoma. So whenever we deal with salivary gland FNAs, we should always keep metastatic lesions in our mind. We shouldn't restrict ourselves to the primary salivary gland neoplasm. Okay. So when we reviewed back the cytological slide, we saw that these cells, although they appeared spindle to ovoid plasmacytoid, but they were showing mild to moderate nuclear pleomorphism, and there was some mitosis which we missed earlier. And when we reviewed the stromal fragment, again, there were no fibrillary characteristic to these stromal fragments. So, so you have to be very careful when you interpret stromal fragments, and you have to be very vigilant, and you have to hunt for mitosis and nuclear atypia when you are dealing such cases. Okay. Okay. Next is 70-year-old male with parotid swelling. So again, the smears were quite cellular, and there was tissue fragments and cells which were small with high NC ratio, and at places showed peripheral palisading arranged in tubules and in sheets. And then there was some stromal fragments, hyalinizing material type. So any guesses? What can this be? So it was given as some cellular basiloid neoplasm. So what is the cytological criteria for this category? First, smear should be cellular and should composed of cells with scant cytoplasm and a high NC ratio. Matrix may be present or absent, but characteristic fibrillary matrix of pleomorphic adenoma is not identified. And evidence of malignancy in terms of increased mitotic activity, tumor necrosis, high-grade nuclear atypia is absent. Matrix pattern can be absent or scant fibrillary matrix, or they can be hyaline stroma or mixed stroma, or they can be no stroma or matrix at all. So depending on the cytomorphological features, there are different differentials. So if you have basiloid neoplasm with scant fibrillary matrix, then your first differential will be cellular pleomorphic adenoma, followed by epithelial myoepithelial carcinoma, basal cell adenoma, adenocarcinoma, and carcinoma X pleomorphic adenoma. If your basiloid neoplasm have hyaline stroma, then your first differential will be basal cell adenoma or adenocarcinoma, followed by adenoid cystic carcinoma. If you have mixed or other matrix, then it's your adenoid cystic carcinoma, followed by polymorphous adenocarcinoma and cellular pleomorphic adenoma. And if you have minimal or no matrix, then again it's your cellular pleomorphic adenoma or canalicular adenoma, myoepithelioma. So there is a long list of differentials, and so we have to work on like that. We put IHC markers to further, um, get the differentials out from the list. So on histology, there was well circumscribed lesion, and this lesion was composed of monomorphic cells which were arranged in tubules, mostly tubules, and there was some solid pattern also. And these cells were positive for P63. The cell block of same patient showed a similar morphology and were positive for beta catenin and negative for MYB. Why we do MYB is specific for which tumor? Adenoid cystic carcinoma. So it was given as a basal cell adenoma. Okay, 45-year-old male with parotid swelling. So we can see that smears are quite cellular, and there are large sheets of ductal epithelial cells, but these epithelial cells, they have abundant cytoplasm, so look like oncocytic change. And in background, there is a bit of mucoid material, but as such, we can't see any mucous cells or epidermoid cells or intermediate cells. Also, there is no significant lymphoid infiltrate in the background. So we gave it as a cellular neoplasm with oncocytoid feature. And so what is the cytological criteria for this category? Aspirate has to be cellular. Neoplastic cells should show oncocytic or oncocytoid features, which means there should be moderate amount of oncocytic granular cytoplasm, round to oval nucleus, plus minus a distinct nucleolus. And there should be no high-grade features of malignancy. Okay. So now once you get this oncocytic rich smears, the background is important. So depending on what kind of background you have, your differentials will depend on that. So if in the background you have histiocyte, proteinaceous debris, inflammatory cells, means it's a cystic background, then you'll think of Warthin tumor as your first differential, followed by sclerosing polycystic adenoma, which is similar to fibrocystic disease of breast, then cystadenoma, acinic cell carcinoma. But again, the acinic cell carcinoma will have a different morphology of these cells. The cells will be more vacuolated type and will resemble the acini. Then mucoepidermoid carcinoma, oncocytic variant. If you have a mucinous background, you will first think of mucoepidermoid carcinoma, oncocytic variant, or rare case of Warthin tumor with focal mucinous metaplastic change. If the background or the cytoplasm is granular vacuolated, you'll think of acinic cell carcinoma, secretory carcinoma, or metastasis like from RCC. And if there's a focal nuclear atypia, then you'll think of high-grade malignancy like salivary duct carcinoma or high-grade mucoepidermoid, okay, metastatic carcinoma. So in this patient, the lesion was solid and cystic, and there was oncocytic epithelium. And at places, there were microcystic change. So we did Elchin blue and pass, and it showed mucin. And these epithelial cells were positive for CK56, and myopithelial cells for P40, and SOX10 was negative. So it was given as mucoepidermoid carcinoma, oncocytic variant. So what is the translocation present in mucoepidermoid carcinoma? Okay. It's your mammal2 rearrangement is there. Okay. Okay. 60-year-old female with left parotid swelling. So the aspirates were quite cellular, and there was predominantly basiloid cells arranged in sheets and small cohesive clusters at basis tubular pattern. And between these sheets, there was some hyaline material which was non-fibrillary, non-laminated. So, any guesses? This is the characteristic cytological finding. So it was given as adenoid cystic carcinoma. So what is the cytological criteria for adenoid cystic carcinoma? The aspirate has variable cellularity. There is a presence of cohesive groups of basiloid cells arranged in small syncytial sheets with irregular borders, sometimes showing microcystic sieve-like spaces, clusters, cylinders, and tubules. And these small basiloid tumor cells, they are uniform and they have scant indistinct cytoplasm. The nuclear features are bland with indistinct nucleoli. Mitosis and necrosis is uncommon. And there is a presence of acellular homogeneous matrix with sharp borders. Okay. So pleomorphic adenoma comes in the differential, but then if you see the matrix of pleomorphic adenoma, the matrix will be fibrillary and it will have fried edges. So we say that there is a melting of the myopathial cells in this chondromyxoid stroma. Whereas in adenoid cystic carcinoma, this stroma will have a sharp interface between the cell and itself. Okay, so cell will be separate from that myxoid stroma. Okay, then these hyaline globules, they can be seen in number of other lesions like polymorphous adenocarcinoma. But then again, this polymorphous adenocarcinoma, it's usually seen in intraoral cavity in minor salivary glands. And also the cells are different. They are not basiloid. They are more of polygonal and medium-sized cells. In basal cell adenoma and adenocarcinoma, these two differentials are difficult to differentiate from adenoid cystic carcinoma on cytology. So we take help of IHC. Basal cell adenoma will be positive for beta catenin. Okay, and then epithelial myopathial carcinoma. Again, in epithelial myopathial carcinoma, the pattern of arrangement will be different. You will get pseudopapillary structures. You will get tubules of ductal epithelial cells. There will be biphasic population, and this hyaline globules will be laminated. They will be not this homogeneous. Okay, then basiloid squamous cell carcinoma. This will come in differential if we are seeing solid variant of adenoid cystic carcinoma, because that can show you some nuclear atypia mitosis, but adenoid cystic carcinoma will lack squamous differentiation. Okay. So on histology, it showed the classical morphology of adenoid cystic carcinoma. So predominantly it was tubular with some cribriform pattern, and the cells were positive for MYB and CD117. Okay. Next is a 15-year-old male with left submandibular growth. So this mass was cellular. They showed stromal fragments and sheets of ductal epithelial cells. And these cells, they were small with the scant cytoplasm, fine chromatin, and they were overcrowding. And the background was mucoproteinaceous myxoid mixed. And there were formhistiocytes, and there were some cells which were showing intracytoplasmic vacuolization. And so this was given as a mucoepidermoid carcinoma on cytology. However, on histology, it showed a different pattern. There was tumor which was infiltrating into the in forms of lobules, and each lobules comprised of tumor cells arranged in microcystic pattern and tubules, and there were lots of secretion in these microcystic pattern. And so on Elshin blue and PAS, there was no prominence of cytoplasmic PAS positive granules. And these tumor cells, they were positive for S100 and GATA3. So, any guesses? So it was secretory carcinoma. Okay. So when we looked back the cytoslide, what we missed? We saw that there was quite a cohesive papilloid clusters of ductal epithelial cells, which we missed initially. Also, these sheets were of monomorphic nature, and then there were multiple of these individual cells which showed microvacuolated appearance in the cytoplasm. Also, the background was not mucinous, it was more of mucoproteinaceous type. Okay, and there were no squamoid cells or intermediate cells seen. So, what is the cytological criteria for secretory carcinoma? The aspirates are cellular, and the cells, they are present singly and in tubular, follicular, papillary groups, and there is no lobular arrangement of normal acinar cells. And individual cells, they are cuboidal cells with low NC ratio in distinct cell borders. And the characteristic feature of secretory carcinoma is that you'll get the single cells with multi microvacuolated cytoplasm. And when you do pass, there will be absence of cytoplasmic zymogen granules. And individual cells, they'll show uniform round nucleus with no features of overt malignant features like high NC ratio, mitosis, marked nuclear pleomorphism. Okay. And in background, you'll see mucoproteinaceous material rather than mucinous background. So what all can be the differential? You can have acinic cell carcinoma, but again in acinic cell carcinoma, the pattern of arrangement will be in form of your normal acini. Plus these individual cells, they'll be vacuolated and they'll show fast positive cytoplasmic granules. Will not get the singly scattered microvacuolated cells in acinic cell carcinomas. Then other differential is your low grade mucoepidermoid carcinoma, which this case was given as. But in this secretory carcinoma, will not see different type of cells, that is intermediate epidermoid or mucous cells. Also, the background will not be that of mucoepidermoid carcinoma. Okay. So in ancillary studies, we can do S100 mamma globin GATA3, which will be positive in secretory carcinoma. It will be negative for P63 calpanin and AR. And on molecular studies, you will get ETVS NTR3 rearrangement. Okay, so now coming to the changes in WHO in salivary gland tumor. So in 2022, more or less the entities were same except adenocarcinoma NOS, which has been further subclassified into mucinous adenocarcinoma, sclerosing microcystic adenocarcinoma, microsecretory carcinoma, salivary carcinoma NOS, and emerging entities. Oncocytic carcinoma and poorly differentiated carcinoma, both the categories has been shifted to the salivary carcinoma, NOS, and emerging entities. Then xyloblastoma, which was previously in 2017, it was placed in uncertain malignant potential, has now been made a neoplastic entity. And the clear cell carcinoma has been renamed as a hyalinizing clear cell carcinoma. In benign entities, canalicular adenoma and other ductal adenomas, they've been reclassified separately into canalicular adenoma, sclerosing polycystic adenoma, keratocystoma, intracalytic duct adenoma. And in other lesions, other tumors involving salivary gland, mesenchymal tumors specific to salivary gland. So there is only silolipoma now, nodulofasciitis and hemangioma has been removed, and so is hematolymphoid tumors. In non-neoplastic epithelial lesions, only two lesions are there: nodular oncocytic adenosis and lymphoepithelial cell adenitis. So I think that's all. I would thank Dr. Sandeep sir and Achal ma'am for helping me with the cases and photography. You can message me your questions.
So I shall be starting. So I'm going to talk about how to approach the fine needle aspirates of pancreas and liver, along with a brief overview of the reporting systems which are available. I hope I am audible and my screen is visible to everyone.
Yes, ma'am. Okay.
Okay. Okay, so if you see the pancreas, so that's the structure of the pancreas. So you have the head and the body and the tail. And so the pancreatic duct travels in this fashion and it joins with the CBD, which is actually coming from the liver and the GB. And then it forms this, both of them, they come and they join and they enter this papilla. So the duodenal papilla they enter into. So in the pancreaticobiliary sampling, so basically you can have a aspirate from the pancreas. So that may be having a ductal lesion or a SNR lesion or a islet lesion. And then you may have something, a sampling from the duct, which may be from the CBD or the pancreatic duct. So either it is pancreatic tissue or it's a biliary sample. So, how do you start when you see a pancreas aspirate? So, since the pancreas is always done in a guided fashion, so most of the times nowadays, so you will get a endoscopic ultrasound guided aspirate, or sometimes you may have a simple ultrasound guided aspirate. And then, so you should look at these endoscopy findings and the imaging findings of the patient and the clinical scenario. Why this is important? Because see, in today's era, if the lesion is resectable and it is inside the bile duct or the pancreas, so you should not sample it. So if the lesion is unresectable or metastatic, then you sample that lesion. Or sometimes there are gray zone lesions. So that means the lesion doesn't have a classical clinical, biochemical, or the imaging findings of a carcinoma or a pancreatitis. So that's why you want to sample those lesions to differentiate between inflammatory versus neoplastic and which kind of neoplasm. Then everybody should be actually well versed that what criteria are being followed at their institution and what is the bias. Then you need to understand that uh, it is actually in cytology also you need to discuss with your gastroenterologist and the radiologist whenever it is required. So you have to step out and discuss with them. So if we see the pancreas, so like 4 or 5 years back, so the Papani-Claus system was introduced for reporting the pancreatic biliary cytology. So in this Papani-Claus cytology reporting system, there were six categories. So the first category was non-diagnostic. So non-diagnostic is like unsatisfactory. That means you have not got enough material at all on which any diagnosis can be made. So that means a repeat aspirate has to be done. Then if you get enough material and you have adequate clinical details and you are not finding a tumor, so that means you have got some inflammatory condition, then it used to be category 2. Then if there is some atypia, which you cannot classify as inflammatory versus neoplastic, so that was category 3. And then category 4 included neoplasm, so mostly benign. And then if the aspirate is suspicious for malignancy, that used to be category 5. And if you are 100% sure with the material that it's malignant, then it used to be category 6. Now, in this system, what was the pitfall? So the serous cystadenoma, teratoma, schwannoma, all these benign tumors, they were in the category of 4. So neoplasms, but benign. Then the other neoplasms that included the intraductal papillary mucinous and so mucinous neoplasms, which are non-invasive, and then the neuroendocrine tumors and the solid pseudopapillary tumor also used to come under neoplastic other. So that means these all were classified as benign neoplasms under category 4. So then, so recently the WHO system has been introduced. Now this appears much better than the Papani-Claus system. And in this we have 7 categories. So if we see the first and second, so they are nearly same. So the first is unsatisfactory, in which the repeat FNAC has to be done. And then the second is negative for malignancy. So this second can actually include all your pancreatitis, which can be acute, chronic, mass-forming pancreatitis, IgG4 related pancreatitis. Then the benign tumor, serous cystadenoma and schwannoma, they are in now category 2, according to WHO, which was in category 4 as per Pepenic law. Then the category 3 is the same, atypia, which we don't know whether it is inflammatory or malignancy related. Then this PAN, low grade and high grade dysplasia, which was earlier in 4B as per Pepenic law. So WHO stratifies it into, as it stratifies for the histology, like low grade dysplasia, if it is there, so category 4. If high grade dysplasia, it is category 5. So basically, these are non-invasive neoplasms. Then again, if you suspect that the neoplasm is invasive, but the material is little scant or maybe the clinical is not matching, so you would like to go suspicious for malignancy, that is category 6. And category 7, when you are 100% sure that it is malignant. So this mostly will include the ductal neoplasms. However, the difference is that the neuroendocrine and the pseudopapillary tumor, so both are now category 7 as per WHO, which actually we were putting in category of benign neoplasms in the Pepenic law. So that is very important, because we know that these neuroendocrine tumors, even if they are grade 1, they can metastasize. So these are malignant tumors, and even SPEN can metastasize. So these are now graded as malignancy and they come into the category 7. Then see, coming to the cases, so now here we can see we have got plenty of the normal SNI. Here also we have got this plenty of the normal SNI. So see, they have abundant granular cytoplasm, they have this rosette and lobular kind of arrangement and the small round bland nucleus. So that means you have got the normal pancreatic SNR tissue. So see, sometimes this may qualify for unsatisfactory or the category 1. And sometimes when the lesion is ill-defined, this may qualify for category 2 also. Then you have to understand that in endoscopic ultrasound, so we travel from the esophagus through the stomach and the duodenum. So you tend to get the contaminant epithelium. So you may get gastric epithelium, you may have duodenal epithelium, you may have esophageal squamous cells. So you have to differentiate those contaminant or the tract epithelium from the pancreatic tissue. So this can be a pitfall. So these contaminant epithelium can be misinterpreted as the lesional tissue. Then that's an example of the IgG4 related pancreatitis. So see, here we can see this is the duct. Then there is this inflammation which is rich in lymphocytes and plasma cells. You have got some fibrosis, and also there are polymorphs. So this is looking like a chronic pancreatitis which has this neutrophilic lesions, also granulocytic, and then the IgG4 stain. So that is negative. So that's an autoimmune pancreatitis type 2. So if it is positive, it becomes type 1 IgG4 related, in which the neutrophils are not there. And the type 2, which is IgG4 unrelated, so that has these neutrophils. So these inflammatory lesions, they will be classified according to WHO as category 2. Then sometimes see, here you have got normal cells. So these are columnar, and see, this is the basal nucleus, which is round to oval. But here see these cells, so they have nuclear enlargement. The cytoplasm is lesser. You have this tiny nucleoli. So these are atypical cells. But if you get just few cells like that, so we can't make out whether it is actually related to an inflammatory condition, so it is reactive, or it is related to a lesion. So that it will be classified as category 3. But if you get lot of cells like this, so then you will classify as category 4, that is low grade dysplasia. Now here we have got, see, a cluster. So it is very tightly packed. And then the cells, they have much bad chromatin. And it is very three-dimensional and compact. And also in the background, see, you have got this neutrophilic debris, some scattered cells, and the mucinous background. So now we know that this is a atypical cell cluster having high-grade dysplasia. Also, there is mucin. So it becomes suspicious for a high-grade IPMN or a MCN. So this is a category 5 lesion. Then sometimes see, you will have an aspirate like that. Now here we have got these papilloid fragments, and these have these vascular cores. So these kind of structures which are running in between the cells, these are the vascular channels. And the cells are beautifully arranged around this structure. So they are forming these papillae. But if you see the outer border of this, so that is irregular. And then here again we can see, so these are like tight fragments. However, we have these scattered cells also. Here again we can see all these branching thick papillaroid fragments. So the papillary architecture is well highlighted here. But here if we see at high power, so these cells tend to look very monotonous. See, they don't have like obvious malignant features. So see, they have moderate cytoplasm. However, the cytoplasmic borders are ill-defined. Then the nucleus is perfectly round, so there is no irregularity of the nuclear membrane. Then the chromatin is like they're looking hyperchromatic, or it may be finely granular. Then the nucleoli are not visible. You don't have mitosis, so mitosis is not there. Apoptosis is not there. There is no necrosis. There is no significant pleomorphism. So that's the classical picture of a solid pseudopapillary epithelial neoplasm. So one is the architecture, which should be papillaroid. Then second, the morphology should be very bland and monotonous. So this tumor looks like a solid pseudopapillary epithelial tumor. So these are more in the young females. So that's why you need to look at your clinical details. Now the closest differential for this tumor will be a neuroendocrine tumor. So if you don't have the papillary architecture and have this morphology, so you need to do immunohistochemistry for chromogranin and synaptophysin to rule out a neuroendocrine tumor, which is the closest differential for this lesion. Now here we can see that here the tumor is looking more malignant. So you have got this clusters and the fragments, but see the cells here. So they have this marked nuclear anisonucleosis. Nuclear membranes, they are irregular. If you see the chromatin, that is more coarse, and even at places the nucleoli are there. And the variation see in the nuclear size and the contours is marked. So that means the pleomorphism is present in this tumor. Again, you can see all these degenerating, karyorectic, apoptotic, and necrotic tumor cells also. So this increased mitosis, apoptosis, that tells you that this is a malignant tumor because you have got a marked nuclear pleomorphism and an increased cell turnover. Again, here also you can see, so the normal ductal architecture is totally lost. So it's a very tight, cohesive fragment which with lot of cellular and nuclear crowding, overlapping, and with marked nuclear pleomorphism. If you see the cell block of this, so see here we can see these glands, and the more important thing in the cell block and the fine needle biopsy of the same case if you have, so you can see this appreciate the desmoplastic stromal reaction. So here the atypia is prominent, but sometimes you may have just bland glands, and if you can identify that desmoplasia, so then also in those cases you can easily clinch the diagnosis of adenocarcinoma. So that will be category 7. Now, this is a endoscopic ultrasound guided fine needle biopsy from another patient. So these FNB samples are also like FNA cell blocks only. So you mostly have see lot of blood, and then you have tiny tissue fragments. See here also we can see the glands, they don't have that much atypia, but just appreciate the desmoplastic response. So this desmoplastic stromal response is even more important than looking at the atypia of the glands. And see, this had a SMAD4 loss. So SMAD4, that's a marker which is lost in pancreatic adenocarcinoma. So if you are confused between chronic pancreatitis related atypia and adenocarcinoma, so SMAD4 IHC can be done. So normally it should be retained, and the tumors, they will have a loss of SMAD4. Then in this case, we can see that rather than adenocarcinoma, you have got these cells with abundant cytoplasm, which is very glassy, and this has this angulated borders. So this cytoplasm actually looks squamoid. And even if you see the nucleus, so it doesn't have the adenocarcinoma characteristics. There is no vacuolation, and see the nucleoli are not that prominent. And see again the cytoplasm that is abundant, that is thick and angulated. So this was a case of adenosquamous carcinoma in which there was some adeno component and the squamous cells which were atypical. So the pure squamous cell carcinomas, they're rare in pancreas. So at times you will encounter a adenosquamous carcinoma. So that also will be WHO category 7. Then this is another example. See, this is a small cell block. So this gland doesn't look very atypical. So see, SMAD4 IHC can be done. So if it is retained, so you may just say that it is not an adenocarcinoma. And see, sometimes there may be a patchy loss. So it may be actually progressing. So this may be a pancreatic intraepithelial lesion. So the SMAD4 reduced staining is important to pick up the intraepithelial neoplasia and the early adenocarcinomas. Then again, here we can see these are other stains which can be helpful, the IMP3 and the P53 staining. So see, P53 diffuse positivity actually helps you in going towards carcinomas. But if it is patchy, so that means it is wild type, and then it is not helpful. And IMP3 staining also, if you see, so see if the score increases, so yes, it goes more in the favor of malignancies. Then this is an example of adenosquamous. So see, here we can see the malignant looking glands. And here we have got some cells which have the squamoid characteristics, which are highlighted with the P63. So see, for the rarer lesions, you should always try to put IHC on the cell blocks. Then this is another example. So here we have got a tumor which has this multiple osteoclast-like giant cells. And see, you have this single mononuclear cells also, which are markedly pleomorphic. So that looks like a poorly differentiated carcinoma, which has bizarre tumor cells and many osteoclast-like giant cells. So a CD68 stain can be done in these cases. So this will actually highlight your giant cells, whereas the main mononuclear cells will be negative. So that's a special type of pancreatic carcinoma, which is undifferentiated carcinoma with osteoclast-like giant cells. So it's a variant of the undifferentiated. Sometimes you may have an undifferentiated carcinoma with no giant cells. Then on cell blocks also you can do PD-L1 IHC nowadays. So if it is required for the treatment, so this actually comes positive. So though it is associated with the adverse prognosis, the advantage is that these patients can take immunotherapy. Now here we have got a bad kind of adenocarcinoma, and then we have got the plenty of the some lymphocytes here, and the tumor cells here are arranged in a solid fashion. So if the PD-L1 IHC is beautifully positive in this, so this patient can be given immunotherapy. Then see, sometimes in the pancreatic aspirate, you can have this kind of a picture. So see here, the cells, they are mostly arranged in these small clusters and rosette-like structures. See, in the center, there is empty space and they are trying to form this flower kind of structure. So there is little tubular and the rosette and the SNR kind of architecture. Again, on the pap stain, you can see the similar architecture, and we can't see any necrotic debris or the mucin in the background. Now at the higher part, if we see, so the cells have moderate cytoplasm and the nucleus is little eccentric. However, if we look at the nucleus, so they are not that pleomorphic. There the chromatin appears little stippled and tiny nucleoli may be visible at some places. This can be better appreciated here. So the stippled chromatin and the tiny nucleoli. But see, there is not much of the nuclear pleomorphism. You can't actually appreciate mitosis or the necrosis, and it has got an organoid or a particular arrangement. So the chromogranin and synaptophysin IHC was done on this case. So that tells you that it is a well-differentiated neuroendocrine tumor. So though it is a tumor, it's not a carcinoma, but according to WHO, it will be classified as category 7. So because these can metastasize. Then this is another case from the pancreas. So adult male with a pancreatic and liver space occupying lesion. Now here if we see, the cells are more disc cohesive. So they are loosely clustered and they are mostly scattered. And at the low part even we can see, so there are these crush artifacts and the cytoplasm and the nuclear material of the cells that is being actually spread out while making the smear. So, and just look at the cytoplasm. So cytoplasmic borders and the cytoplasm is not clearly visible. So the nuclei, they are looking very big. So here also if we see, so the nuclei, they look very pleomorphic, and see they are oval and plump, round to oval. And if we see the chromatin again, it is stippled, and see here, so these are the apoptotic cells. So that means this tumor has a high turnover. So if you find lot of these mitotic and apoptotic bodies, so that tell you that it's a rapidly proliferating tumor. Again, the cytoplasm is not neatly visible. So they have a high NC ratio, marked nuclear pleomorphism, lot of crushing and the mitosis and apoptosis. So that tells you that it's a high-grade carcinoma, not a low-grade tumor. So because it is looking neuroendocrine, so again, you'll require IHC in this kind of a case. So that's the higher part. The stippled chromatin is very nicely visible along with this frequent apoptosis. Now the cell block from this case, so it again showed the similar morphology. So see, you have got cells which have a high NC ratio, and then the chromogranin synaptophysin was nicely positive. INSM1, that's a nuclear marker for the neuroendocrine differentiation. So that's also positive. Then the Ki67 is very high. So this Ki67 again reconfirms your morphological diagnosis that it more looks like a neuroendocrine carcinoma rather than a tumor. So it was a small cell neuroendocrine carcinoma. So once you can make out that it's a neuroendocrine carcinoma, the next point is that you try to differentiate whether it's a small cell neuroendocrine carcinoma or a large cell neuroendocrine carcinoma. So since the cells are not large here and you don't have the nucleoli, so it's a small cell which is much more common than the large cell neuroendocrine carcinoma. Now, sometimes the small cell carcinomas, they may be confused with this non-Hodgkin's lymphoma. So this is a case of a pancreatic aspirate. So the cells are totally scattered. They don't have any cohesion. So this kind of case, so that will require again a immunocytochemistry. So if so you actually get so you can do an initial panel of a CD20 and CD3 because the pancreatic lymphomas are rare and mostly you will have a B type lymphoma, a diffuse large B cell lymphoma. Then the metastasis in the pancreas, they're quite rare. Now let's see an interesting case. So here we can see that this is the normal pancreatic tissue in an aspirate, and these are some cells which are singly scattered. See here, and they have this cytoplasm and pleomorphic nucleus, and they have this prominent nucleolus. Again, see, this was the cell block, and we got the similar cells. And see, on immunohistochemistry, so on the cell block which was performed, so GATA3 was positive and P40 was positive. So when we actually collected the detailed history from this patient, so this patient had presented like a advanced carcinoma pancreas. However, he was actually a known case of carcinoma urinary bladder who was on treatment post BCG, and he had no recurrence in the bladder. So actually, this was a metastasis of the urothelial carcinoma into the pancreas, and it was a big mass which was involving the porta and the pancreas. However, there was no recurrence in the urinary bladder. So sometimes you will encounter that kind of uncommon cases. So that finishes the pancreas. So if we see the liver aspirates, so in the liver, so mostly, so either you will get a aspirate from the hepatic parenchyma, or then the more common lesions which you tend to get sometimes are from the gallbladder. So if we see the normal cells, so that's the look of the normal hepatocytes. So these are polygonal cells. They have abundant cytoplasm, round nucleus, and binucleation is common. Even the nucleoli, they may be there, and you may have lipofuscin pigment, some vacuolation, or the bile. So that helps to identify that those are hepatocytes. Then if you see the duct epithelium, that looks like this. So you can see in the liver, you can see in the pancreas. So that is flat monolayered sheet, and the cells are columnar. So you may appreciate sometimes the palisading and this feathery appearance at the edges. And see, they are very monolayered, and the cells are regularly placed. So the nuclei are separate from each other. There is no overlapping, and you have abundant cytoplasm in these cells. So in the liver aspirate, so what will you do? Once you actually start seeing a liver aspirate, look for the normal hepatocyte. So just hunt for the native tissue. Why is that important? Because see, in today's era, metastasis is much more common than the primary tumor, and it is the most frequent tumor in liver. So you will rarely see a aspirate from the primary liver tumor. Mostly you will have a metastasis. So if we see some cases, so that's one example. So here we can see this dense acute inflammatory exudate, polymorphs, lot of polymorphs here, necrotic debris. So that's a pyogenic kind of a liver abscess. See, sometimes you may have totally this caseous kind of necrosis. So you can do a AFB stain. So yes, in our country, so till date, we tend to see tuberculosis involving every other organ. Then this is another case. So this looks like a tumor. See, it is a cellular aspirate, And if you see at the low part, so you have these big fragments, and see these are the vessels which are crossing these fragments. So at the higher part, if we see, so see central vessels you can see in many tumors. What is more important to see is the peripheral sheathing by the endothelial cells. So if you have this kind of peripheral layering by this sinusoidal kind of endothelium, so that is very specific for the primary hepatocytic tumors. So here we can see trabecular architecture and the peripheral endothelial cells, and here we can see the central endothelial cells. So if we look at the cellular features, so we have got big cells with lot of cytoplasm and the big nucleus and the prominent nucleolus. And see, we have got the crowding, we have got nuclear enlargement, we have got nucleoli. So that looks like a well-differentiated HCC. So as it will become moderately differentiated, it is more easy to click. So here we have got much more pleomorphism, much more nuclear enlargement, and the bigger nucleoli. So see, this becomes more easy. Even the nuclear inclusions are there. Then sometimes they become then poorly differentiated again. Then you have to differentiate these from the metastatic other carcinomas. See, here we have got much more mitosis, and these are atypical mitosis. So in these poorly differentiated, you will need sometimes immunohistochemistry to differentiate from non-HCC tumors. Then this is a special variant of HCC. So here we have got cytoplasm, which is abundant, but this is again dense. So this is very dense and glassy kind of cytoplasm. See here also. And even the nucleus will be big. And this cherry red kind of very big nucleolus or a macronucleolus is seen in the fibrolamellar carcinoma. And then sometimes if you are lucky, you may get some fibrotic stroma, which is classical of the fibrolamellar carcinoma. So that's a spatial variant which you see in non-cirrhotic patients and the younger patients. Then after HCC, if we talk about the primary tumors, so you may encounter an aspirate from a cholangiocarcinoma. So that will look like just any other adenocarcinoma. So you have got these fragments where there is nuclear enlargement. Sometimes you may have the mucin also. So that's a adenocarcinoma. Now, it is impossible actually to differentiate a cholangiocarcinoma vis-a-vis a metastatic adenocarcinoma in the liver. So here also we have these papilloid fragments, some acinar structures, and the cells, they have vacuolated cytoplasm. So it looks like a classical ADCOM. Then if you see the liver, so I told you metastases are much more common. So sometimes you may have subtle pointers. Like here you can see signatoring cells and this intracellular mucin. So if you get the history that the patient has a stomach mass, so you know that it is a gastric ADCA which is metastasizing to liver, which has signatoring cells. So this patient had a periampullary mass and the aspirate was done from the liver. And see now here it is looking little different. So it is looking more biliary kind of ADCA. And this is the cell block. So here you have got this small rosette kind of arrangement. And if you look at the cells, so they are like intermediate sized cuboidal to columnar. So that's a biliary pattern of the adenocarcinoma. Then sometimes these adenocarcinomas, they can be very poorly differentiated, like here. So they are getting, the cells are getting scattered, the pleomorphism is becoming more, there is more necrosis. Then at times you can have other metastases. See, so that was all about the adenocarcinoma kind of metastasis, which are coming from the lung or the colon. Then you can have this breast carcinoma metastasis. So nowadays very good IHCs are available. So a GATA3 or TRPS may be performed. Both of these are nuclear markers, and they will tell you if they are positive that the metastasis is from breast. And then another which can mimic breast carcinoma is a melanoma. Now the melanoma, that again has plasmacytoid cells, and again you can take the help of the IHC. So this SOX10 is a nuclear marker which picks up the melanoma, or you may do HMB45 or melanocyte, which are cytoplasmic. Then another tumor which can metastasize to liver is RCC. So see, this is a case we had. So this was a known case of RCC, and these RCC metastases can actually mimic a HCC, because again the RCC cells are very big. They have this abundant vacuolated cytoplasm. So you have to have the history in these cases. However, the cytoplasm is actually much more vacuolated in a RCC as compared to HCC, which is very helpful. Then you can do a IHC for PAX8, that's a nuclear marker for RCC. And CA9 also can be done, which is specific for a diagnosis of RCC. Sometimes even adrenal tumors can metastasize to liver, and they may mimic a HCC. Then this now looks a non-epithelial tumor. You have this stroma and the proliferation looks more spindled. So you have this plump oval to spindle cells, and it is a very cellular tumor. So this patient was a known case of GIST, which was spindle cell type, and this was a metastasis in liver, which was post-resection. So in these cases, actually, you can put up the IHC for CD117 and DOG1. So both of them, they actually beautifully highlight the gastrointestinal stromal tumors. So yes, we get many cases of this just metastasis into liver, and especially in the patients who are unresectable and then who are on therapy and they get additional lesions. So this is cytology becomes quite an effective tool for the diagnosis of just in the metastatic lesions. Then you can have non-GIST kind of a tumor. So here we can see that we have got this cellular spindle cell tumor. However, there is too much of a palisading while the pleomorphism is less. So this was a schwannoma in the hilar region, which was actually mimicking a cholangiocarcinoma and a IgG4 related disease. Then yes, the lymphomas are also quite common to metastasize and involve the liver. So in them, the aspirate will show mostly singly scattered cells. Then if we see the pediatric liver tumors other than the adults, so in pediatric, so you have to keep in mind that yes, most common pediatric liver tumor aspirate you will encounter will be from the primary tumor, in which the AFP is very helpful. So like this is 1 year, AFP was 1 lakh. Large hepatic mass. So even see with the clinical history, you can guess that the aspirate should mostly show a hepatoblastoma, which is the most common primary tumor, which is associated with this kind of elevation of the serum AFP. Again, the radiology is very helpful. Now here we can see this, see hepatocytic looking cells only. Now here they are forming these trabeculae, and whereas in the this lower part of this image, they are more crowded. The cells are more crowded and the NC ratio appears higher. If we see at the higher part, see here we have got these trabecular fragments, and we have see some central vessels. We have little this SNR and this pseudo rosette kind of arrangement, and there is some scattering of the nuclei. But the most important point is the NC ratio is low, cytoplasm is abundant, and if you see the nuclei, so see perfectly regular nuclear membranes, fine chromatin, tiny nucleoli, no mitosis. So this looks like a fetal portion of the hepatoblastoma. Whereas in the other areas, these are more compactly arranged. The cells and the nuclei, they are crowded here. And if we see here, so again, the NC ratio is high. And if we look at the nuclei, so you have got a more pleomorphism, bad chromatin, and see, you have actually got an increased turnover. So you can see the mitotic figures also. Okay, so see multiple nucleoli and the irregular nuclear membranes and the bad chromatin. So that tells you that this is the embryonal portion of hepatoblastoma. Now, the other findings which may help in the diagnosis of hepatoblastoma, one is the EMH. So you may have these erythroid and the myeloid cells and the megakaryocytes accompanying the tumor. This is a very helpful feature for making a diagnosis of hepatoblastoma. Then you may have this SNR pattern that is more common in embryonal pattern, but it may be seen in any component. Then the stroma sometimes may be aspirated, but mostly in the cytology aspirates, it is scant. Then sometimes even the presence of bile may be there. So it is quite uncommon in hepatoblastoma. It is more common in HCC. Then this false vacuolation may be there, which may actually, this may mimic signet ring cells. Then mitosis and apoptosis. So I told you, so the embryonal areas will have more mitosis and apoptosis as compared to the fetal areas, but they do tell you that that's the proliferative area of the tumor. Sometimes you have small cell undifferentiated type of hepatoblastoma, so this will look like any other malignant small round cell tumor. So it is very difficult to differentiate without immunocytochemistry. But this, and moreover, it doesn't cause an elevation of the AFP. So it may be mistaken for other malignant small round cell tumors. So IHC has to be done to exclude all those tumors, and a close correlation with the clinical and the imaging findings is required. Then you can use the SAL4 IHC for actually subtyping of these hepatoblastomas. So the SAL4 IHC actually beautifully highlights the embryonal component, and the fetal is actually negative or it stains weakly. So we did this study, and so we correlated with the survival also. So a higher score is associated with a lower survival. So if you have a higher IHC, so that means it is more proliferative and the bad tumor. So those people, they have bad survival. Then sometimes other than hepatoblastoma, you may have other primary tumors also. So like this was a 4 years male and the AFP is elevated, but it is not in lakhs. Now here again, we have got this trabecular pattern. So again, hepatoid looking cells and central crossing vessels. But see the central crossing vessels and there is some peripheral vascular wrapping also. So that's the difference. So now here, even if we look at the cells, the cytoplasm is more and the nuclear enlargement and the nucleoli are more prominent. Despite that, the cytoplasm is lot. So this looks more like a hepatocellular carcinoma rather than a hepatoblastoma. Then the presence of bile can take you towards HCC and the absence of EMH also does help. So if you have like these big tuberculae, macro tuberculae, which are very well formed and the macronucleoli, so you should go towards HCC. So again, here we have got lot of tumor giant cells also. So this is HCC and HCCs are much bad than hepatoblastomas in children. So yes, you have to have the other differential also in mind. So when the presentation is not classical. So the pediatric HCC also you can try to diagnose on cytology. Then this is another case, 1-year-old child, he had a large mass and the serum AFPC, it was normal, but this mass was huge and it was solid. So a FNA was performed. But see, the aspirate was not that cellular. So we have got this fragment. And if we look at this fragment, so it looks like a ductal fragment, but it is not looking like a normal duct. Why? See, it has got a very complex architecture. So this is like very twisted, angulated, and complexly branching duct. And if we look at the nuclei, so nuclei, they are bland. So they don't have significant nucleopleomorphism. There is this mild overlapping and little nucleolus. But see, you don't have mitosis, you don't have necrosis, you don't have hepatocytic looking cells. So why are you getting all these complex ductal profiles? Again, see this ductal profile, it is quite twisted. And there is this mild nuclear atypia. So in a child, this kind of aspirate, what is this telling to you? So again, we have got like here, see complex ductal structures, again a complex ductal structure. But see, you don't have like cholangiocarcinomas or adenocarcinomas. Here you've got some, see, stroma. Now this is some fibrous stroma and there is this myxoid kind of substance also. And there are these scattered normal hepatocytes also. So this actually looks like a mesenchymal hematoma kind of lesion. In the cell block also we got similar material. So these are the ductal profiles. So we gave the possibility of a benign liver tumor, possibly mesenchymal hematoma. So the resection was done and this was the resection of this specimen. And see, classically mesenchymal hematomas are like this. So they are cystic. And if you put a needle, you will not get anything. You will get just material, which is acellular. So here we have got a solid lesion and that's why they had aspirated. If we see the histology, so histology was classical. So this is abundant fibromyxoid stroma. And in that, you see these branching kind of ductal profiles, which look like actually fibroadenoma if you see in the breast. And then these are surrounded by these stellate kind of fibroblasts. So see, this is the kind of stroma which actually condenses around these ductal profiles. So this abundant stroma, this peculiar arrangement of the ducts and the condensation of the stroma around this, so that all tells you that this is a classical mesenchymal hematoma. So this CK19 is highlighting the ductal profiles and see the scant hepatocytes which are seen in the lesion. Then at times you can have this malignant spindle looking tumor in the liver. So see here you have got this plump, bizarre kind of cells. They don't have any pattern. And see there are bizarre tumor giant cells also. There is some stroma. So these kind of pleomorphic sarcomas in liver. So if they not metastatic, so embryonal sarcoma should be kept a possibility. So in this tumor, so you may have these eosinophilic globules which are of help. So these stain positive for PAS. And then you have these scattered inflammatory cells. The closest differential for this tumor is a rhabdomyosarcoma. So you have to exclude the other pleomorphic sarcomas of the children because this doesn't have any specific IHC. So basically, you have to exclude other sarcomas and then make this diagnosis. This is also a quite bad tumor. So this possibility has to be entertained. Then children can also have a lot of metastatic lesions in the liver. So mostly you will have that malignant small round cell morphology. So you may have a neuroblastoma, Ewing's tumor, rhabdomyosarcoma, or the Wilms metastasis, or the lymphohematopoietic tumors. Now this is an example of the Ewing's metastasis. So you can do a IHC for the MYC2, NKX 2.2, and a FISH for the translocation for the Ewing sarcoma. Then this is another example of a malignant small round cell tumor, see, and in this we had this neuropil kind of material and the rosettes. So we did synaptophysin on the cell block. So it is quite helpful. The cell block was very helpful in this case. Then this is another of case of our department. So here we can see the large pleomorphic cells and see these are having this. So we have these donut kind of cells also and see marked apoptosis. So that's a high grade lymphoma and ALK1 and the CD30 immuno was positive. So this was a metastatic ALCL in a child. Then yes, rarely you may have this metastatic carcinomas also. And this is one of the case published from our department. So this was a nasopharyngeal carcinoma. And then if you prepare the cell block and do the immuno, so yes, you can clinch those kind of diagnosis. Just a few words about the gallbladder lesions. So this is an example of the xanthogranulomatous cholecystitis. Here you have got an exudate which is rich in polymorphs and histiocytes, and there is this granulation tissue or the proliferating capillaries. So this is a mimicker of carcinoma. So yes, many times you will get an aspirate of xanthogranulomatous cholecystitis. Then this is a adenocarcinoma which is well differentiated, that is very easy to diagnose. So most of the times you'll encounter adenocarcinomas, and then sometimes they can be poorly differentiated. You can look for the presence of the mucin. Then this mucinous tumors, yes, if they have abundant mucin or focal mucin, you should try to put it in the report, because the tumors which have greater than 50% of the mucin, they behave differently, whereas which have greater than 70%, which are pure mucinous or colloid, they are different. Then sometimes you have this pure signet ring cell kind of a carcinoma. So this is much poor prognosis. Then yes, since we in North India we have a high incidence of GB, we frequently see adenosquamous carcinomas. So see here we have got this cells with this angulated thick cytoplasm and then pycnotic nuclei. So these are typically keratinized cells, and a P40 IHC can be done. So that's adenosquamous carcinoma. Now this is again an example of a neuroendocrine carcinoma. So we have already seen in the pancreas. So this was of the gallbladder. So you can get a small cell carcinoma in the gallbladder, and once you get a neuroendocrine tumor in the gallbladder, at least the minimal is that you try to make out that whether it's a tumor, so whether it's very organoid and low grade, or whether it is a carcinoma. So yes, gallbladder carcinomas, you can try to classify on the cytology. That's important because see, in our country, we tend to get aspirates from the advanced cases. So the therapy is going to depend upon this, because they are not going to be resected and you may not get a biopsy. So sometimes the cytology may be the only material. So to conclude, so the diagnostic approach, so you see in the pancreas, first you try to make out whether it's an inflammatory aspirate or it's a neoplastic aspirate. So if you are confused, so you go category 3 and you ask for a clinical correlation, a repeat, or a biopsy. Then if you are sure that you are looking at a tumor, so you have to make out that whether it is a adenocarcinoma. Metastases are very rare, so it will be primary in the pancreas, and adenocarcinoma is the most common tumor you will encounter. If it's a adenocarcinoma, so you can just look at the amount of the mucin, the signet cells, and the grade. If it's a non-adenocarcinoma looking tumor, so try to make out, is there a squamoid component, or is it a neuroendocrine carcinoma? If it is not looking a malignant tumor and a low grade tumor look is there, so you have to keep the possibility of a neuroendocrine tumor and a solid pseudopapillary neoplasm. In the cystic lesions, look for mucin and the scant cells, because these aspirates are paucicellular. At times, you may have metastasis. Amongst the metastasis, RCC is the most frequent metastasis you will encounter in pancreas. Again, the mesenchymal tumors and the lymphoma are rare in pancreas. If we talk about the liver, so again, at the first go, try to make out whether that's an inflammatory or the neoplastic aspirate. If neoplastic, you have to hunt for the normal hepatocytes and the bile, and try to look whether there is single population or a dual. So whether it's a primary tumor or metastatic, because metastatic is more common in the adult. Then if you make out that it is primary tumor, then try to put different differential as per adult and pediatric. If it's metastatic, then try to make out whether it's epithelial or it's non-epithelial. Then go and collect the history, whether there was any other tumor. So do we have any surgery, any therapy? Then if it is a adenocarcinoma, then it can be a primary cholangio or it can be a metastatic. In the GB, again, try to differentiate whether it is xanthogranulomatous or it is neoplastic. In the neoplastic, you will have mostly adenocarcinoma. Then in adenocarcinoma, try to pick up the mucinous adenocarcinomas and the signet cell adenocarcinomas. In the non-adeno, try to make out whether there is squamous or the small cell neuroendocrine differentiation. And then look for the background hepatocyte. So whether it is infiltrating the liver or not. If you have liver metastasis, then how to actually approach these metastases? See, in the adult, mostly the metastases are epithelial and they are from adenocarcinoma. Then after adenocarcinoma, you may have metastasis from NETs and so neuroendocrine tumor and neuroendocrine carcinoma at times. So these adenosquamous and squamous metastases are much more less common. At times, you will have the RCC and adrenal metastasis, which can mimic primary. Then, if it is not epithelial, so spindle cell tumor metastasis may also be seen. Try to classify into GIST versus non-GIST tumors. Then, if the population is totally scattered, so that is mostly lymphoma or melanoma. In the child, mostly you will have small round cell tumor. So, entertain the differentials of Ewing's, rhabdo, neuroblastoma, lymphoma, and uncommonly or rarely epithelial or spindle. So these are the take-home message. So see, in the resectable liver GB or the pancreas lesion, you will not get an aspirate. So they are not to be sampled. So mostly you are getting the aspirates in lesions which are multiple, which are metastatic, unresectable. So they have a known primary elsewhere. So always collect the clinical history. Then the lesions which are like confusing for the clinician in the sense that inflammatory versus neoplastic, they will be sampled. So in this, our role becomes very important. In the liver, always remember metastasis is much, much more common than the primary. Then for HCC, yes, you should not get aspirate because the current imaging guidelines don't recommend that. Only a few cases will have primary HCCs. So a clinical and imaging correlation is a must. Then details of the previous FNA, biopsy, surgery, or the therapy. Always try to prepare a lot of smears of the cell block so that you can do a immunocytochemistry. You have to understand the limitations of the scant material and the pitfalls to avoid the false negative and the false positive. Always do a cytohistocorrelation and a retrospective review of your cases so that we can improve our understanding. So I would like to thank Professor Iyer, Professor Mathur, and Dipali ma'am for mentoring during my journey. So that's all from my side. So are there any questions? I will see in the chat box. So if anybody has any questions, so please let me know. So you can type in the chat box. So I have not discussed the ancillary techniques and I've not got into the complex scenarios and the clinical part because since it is a very big topic, so to cover liver, gallbladder, pancreas in a one talk, it's difficult. So if you have any queries, you can always contact me later also. So you can mail me. Thank you, everyone.
Okay, so is my screen visible? Uh, can someone please unmute and tell?
Yes, ma'am.
Okay,
Okay.
okay. Thank you so much. Thank you. So, in this session, we will discuss about fluid cytology reporting system and cell block immunocytochemistry. So, serous cavity frequently accumulate fluid in various pathological states, both neoplastic as well as non-neoplastic processes. So, fluid can accumulate in any of the serous cavity like pericardial cavity, peritoneal cavity, or pleural cavity. So the serous cavity is lined by low cuboidal epithelium with underlying loose connective tissue. Now, cytological evaluation of serous fluid is widely used in the initial evaluation of the etiology of effusion because it has high diagnostic sensitivity. Effusion are easy to drain and minimally invasive procedure and can be used as a palliative part of treatment. Then it is readily accessible and inexpensive, and it is a viable alternative to tissue biopsies. And increasingly relevant diagnostic molecular test enables selection of appropriate therapeutic target and personalized medicine. So effusion can be neoplastic or non-neoplastic, can be due to any type of malignancy. Primary effusion, primary tumors of serous cavity are quite rare. And cytology can help in establishing the site of primary, help in determining the stage and recurrence, and it allows the use of ancillary techniques. Now, after receiving the fluid, we can cytocentrifuge the fluid to prepare the smears, and we can make the direct smearing by using soiling action. So we have to make two type of smears, pap smears and Giemsa smears, and then for ancillary testing, cell block preparation should be done. So cell block have many advantages and play a pivotal role in cytology. The architecture present the cell block resemble the histopathology sections, and it increases the diagnostic yield due to provision of ancillary studies like histochemical stain, immunocytochemistry, or molecular studies. There are various methods of cell block preparation, and there is no standardized method, and the methodology or procedure varies from lab to lab. Few are commonly available methods and few are commercially available with automated methods are also there. Clot technique is the easiest and most commonly used technique for cell block preparation. And here we can see blood clot or predominantly blood with atypical cells or tumor cells. So we can use this type of cell block preparation for immunocytochemistry. Agar method can also be used. So agar can be used to form a solid cell pellet for cell block, and it is a cost-effective method, and it is optimum for immunocytochemistry. So heat regulation is the only limitation of agar method. Then there are a few other methods like centrifugation, sediment cell block technique. Then plasma thrombin can be used as an adjuvant to centrifuge cell pellet and to produce a firm clot. And they are compatible with immunocytochemistry and most molecular testing. Only limitation is uneven concentration of cells within the clot. Now, the reporting system. Why we need a standardized reporting system for fluid cytology? So we all know that diagnostic efficacy of effusion cytology demonstrate variation because of different collection and preparation techniques, then various cytomorphological overlap between benign and malignant entities, and varying interpretative experience of the cytopathologist, that is inter-observer variation. That's why we need a standardized reporting system. Other practical questions like evaluating the evidence of adequacy in the form of volume and cellularity, then defining what is true negative sample and judicious use of category ATP and suspicious, then revisiting the value of cytology in the diagnosis of mesothelioma and reporting the presence of epithelial cells in peritoneal washing. So the International System for Reporting Fluid Cytopathology was given by International Academy of Cytology and American Society of Cytopathology in 2020. Aims of this reporting system are to improve diagnostic yield and inter-observer agreement, to define definitive criteria for each category, to provide diagnostic categories with well-defined risk of malignancy, to enable better clinical management with emphasis on diagnostic pitfall, and to improve the role of ancillary testing in context of each category. Now, the reporting format should have these four categories: first, specimen type, location, and procedure; then adequacy, whether specimen is adequate or not; then TIS category, sorry, diagnostic category, and notes and comments in the form
Ma'am, your audio is not coming.
now it's audible.
Yes, ma'am. Yes.
Okay, okay. So the first category is non-diagnostic category. So a specimen that provides no diagnostic information can be reported as non-diagnostic, and a repeat sample can be asked if in a particular clinical context. So if the sample is acellular, highly degenerated, or hemorrhagic sample, then you can give a report of non-diagnostic. Now, the adequacy criteria. So for adequacy criteria, it is not like that, like in thyroid or other cytology, like in cervical cytology, you have a definitive cellularity or adequacy criteria on the basis of cellularity. But for serous fluid cytology, we can't set a cellularity criteria on the basis of number of cells. So defining adequacy by a minimum cell count of benign mesothelial cells or inflammatory cells is not feasible, because it would require different criteria for distinct entities. So if you have a specimen from pleural tuberculosis and you are getting only lymphocytes, it is adequate in the term of being representative of that particular disease, and you can give a diagnosis of negative for malignancy, and then you can write kindly correlate with the clinical findings, and patient can be workup for tuberculosis. 50 to 75 ml may be considered adequate volume, but there is no strict criteria. Higher the volume, the smaller the number of samples reported as non-diagnostic or atypical. Then cellular content acceptable to find only lymphocytes, neutrophils in benign effusion, and diagnosis of malignancy with one cell population may be made without mesothelial cells. So a well-preserved, well-prepared, well-stained, and easily visualized smear is ideal for fluid cytology. Now here in these photomicrograph, we can see that in this first picture, we can see that the cellular details are obscured by hemorrhage. We can't see the cellular details. Here again, we can see cellular details are obscured by blood as well as crystals from the anticoagulant. In this picture, we can see that a drying artifact is there. So interpretation is not possible on cellular morphology. So in all these type of cases, we can give a diagnosis of, we can report it as non-diagnostic. And non-diagnostic report indicates that a repeat sample must be taken and evaluated in a relevant clinical context. Second category is negative for malignancy. So when the specimen is composed of only benign or reactive cellular components without malignant tumor cells, you can give a diagnosis as negative for malignancy, and varying ratios and type of inflammatory cells can be seen. It also includes effusion due to infectious causes. So majority of effusion samples are interpreted as negative for malignancy, and a negative for malignancy report indicates that the patient must be treated for the diagnosis provided and or kept for clinical follow-up. So criteria to call a sample negative for malignancy are mostly mesothelial cells. Then you can see mesothelial cells binucleation and multinucleation. Then variable inflammatory components, histiocytes and giant cells can be seen. And it can include other benign components like samoma bodies, collagen balls and organisms, etc. Now let's talk about commonly encountered cells in serous fluid cytology. So most commonly seen cells are mesothelial cells, which can be seen free floating or in clusters. So here morphology of, we can see morphology of mesothelial cells. So they have a flat cellular membrane, abundant cyanophilic cytoplasm, and there is a clear space in between two mesothelial cells, which is known as window. So formation of this clear space occur because of presence of interdigitating villi, which can be seen on electron microscopy, and they are not visible on light microscopy. Centrally placed nuclei, round nuclei with small prominent nucleoli can be seen. Then binucleation and multinucleation with frilly or frilly cytoplasm, and you can see brush border surrounding the cell membrane and cytoplasmic blebbing surrounding these brush borders. Now, reactive mesothelial cells. So many a time these reactive mesothelial cells mimic atypical cells, and it is difficult to differentiate on the basis of morphology. So if there is any difficulty, then we can go for few immunocytochemistry marker to confirm. So they have wide morphological spectrum. They can be seen in clusters or clump. They have pale cytoplasm, prominent nucleoli, and diffuse cell borders. So here we can see that this is a case of, I think, 40-year-old female. So here we are getting mesothelial cells, and at few places they are forming gland-like structures. So in this case, we can thought of reactive mesothelial cells as well as of any malignancy. So it is always important to differentiate these reactive mesothelial cells from cells of mesothelioma as well as cells of any secondary metastatic carcinoma. Other cell type is histiocytes. So it is very challenging to differentiate histiocytes from mesothelial cells based on morphology alone. So there are few morphological clues to differentiate, like histiocytes will not have windows. Then cytoplasmic vacuolation can be seen with phagocytosed material. Then they will have ill-defined blebs and blend cytoplasm. And then kidney-shaped nucleus will be there with indistinct nucleoli. Now we will discuss about various patterns of benign serous effusion. So if you are getting a serous fluid with showing predominantly neutrophil, irrespective of the presence or absence of mesothelial cells, you can report it as negative for malignancy and suggestive of empyema in case of pleural fluid. So empyema is most common cause of infection caused by infection and rarely can be seen in other conditions like rheumatoid arthritis. Then if you are saying neutrophil predominant effusion in ascitic fluid, then it is indicative of spontaneous bacterial peritonitis. And in case of pericardial effusion, bacterial pericarditis. Then you can also get predominantly lymphocytic rich effusion, and the common causes are tuberculosis and viral infection. So various type of lymphocytes can be seen, but you should always keep in mind that T cell rich predominant pleural effusion is most commonly associated with a reactive process. So like in this case, so this was a case of 64-year male. We got pleural fluid, and here we can see there are numerous predominantly lymphocytes are there, and mesothelial cells were not there. And so we thought of low-grade lymphoma. Then we did IHC, immunocytochemistry using cell blocks. So I don't have images of those ICC. I didn't get those images. So CD3 was diffusely positive and CD20 was positive in few cells, like intermixed between the T cell positive T lymphocytes. So then we gave a diagnosis of suspicious for malignancy and suspicious for T cell lymphoma, and we advised flow cytometry. Then on flow cytometry, we found that 93% of these cells were T lymphocytes with normal immunophenotype. So it should always be kept in mind before making a diagnosis of T lymphoma involvement in effusion cytology, because reactive process can mimic the lymphoma cytology. So immunophenotyping by flow cytometry can help in differentiating these entities. If you're getting more than 10% eosinophils, the causes could be pleural fluid aspiration or allergic conditions. Many other conditions like hypereosinophilic syndrome, malignancy, infection, and pulmonary infarction can also be there. Then there are a few unexpected cellular and non-cellular findings you can get in fluid cytology, and you should be aware of these findings, because like if you are getting Samoma body, you can't think of directly that it is a metastatic papillary thyroid carcinoma or it is suggestive of some ovarian high-grade serous carcinoma. So you should know that what findings are normal for a fluid cytology. So Samoma bodies are concentrically laminated calcification. They can be seen in papillary mesothelial hyperplasia, endometriosis, and endosalpingitis. Then you can get collagen balls. So collagen balls are basically here you can see three-dimensional clusters of collection of collagen and surrounded by mesothelial lining. So they can be seen in the patients of peritoneal washing, and they originate from the projections commonly from the surface of ovary. Now, detached ciliary tufts, that is ciliocytothera type changes you can see. So in peritoneal washing of many women, and they originates from ciliated epithelium lining and often be mistaken from the parasite. So you should be cautious and you should keep this thing in mind that ciliocytophoria can mimic parasite. Then you can get ferruginous body in case of heavy asbestos poisoning, which is extremely rare in serous fluid. Then fluffy ball of bacteria, suggestive of actinomyces, you can see. Then broad septate hyphae with acute angle branching, suggestive of aspergillus. So all these findings can be seen in serous fluid cytology. Then this is a sample from an effusion related to rheumatoid serositis. So here we can serous effusion. So here we can see lymphocytic, degenerated lymphocytes and neutrophils in a felt-like proteinaceous background. You can see focal necrosis and multinucleated giant cells, which are elongated at periphery. Now, LE cells, so classically seen in serous fluid effusion, related to systemic lupus erythematosus. So here you can see they consist of cell neutrophils or macrophage, which engulf a so-called hematoxylin body. Extramedullary hematopoiesis is rarely occur in serous effusion. So if you suspect a case, then before making a diagnosis, you should look for megakaryocyte and other hematopoietic elements. Now, the third category is ATP of undetermined significance. So, if a specimen that lacks quantitative or qualitative cytological features to be confidently diagnosed as either benign or malignant, if the sample exhibits sufficiently clear morphological features to exclude the possibility of classifying them as non-diagnostic, and you will get atypical macrophage morphological features identify more closely approximately benign, reactive, or degenerative as compared to malignant features. So if you are getting small number of atypical cells and you are not sure whether the effusion is malignant or not, then you can give a preliminary report of ATP of undetermined significance, and then you can proceed further for immunocytochemistry. So if immunocytochemistry demonstrate macrophages or mesothelial cells, then you can give a report of negative for malignancy. Whereas if ICC demonstrate epithelial origin, then a final report of suspicious for malignancy or malignant secondary can be given. If the sample is insufficient representative, like if you are not have a proper good cell block or ICC is equivocal, then a final report of AUS can be given. What are the criteria to call a sample AUS are mild to moderate nuclear enlargement with slightly increased NC ratio, prominent nucleoli, then slight nuclear membrane irregularity, altered chromatin, and altered cytoplasm. So there are few scenarios in which you can give a report of ATP of undetermined significance, like if you're getting artifacts in the specimen or degenerative changes in mesothelial cells and macrophages, but you're not confident to call them benign. Or you can get mesothelial proliferation, but they are indefinite for a diagnosis of suspicious for malignancy. Then lymphocytosis can be there. So you can't rule out lymphoproliferative disorders if you are getting, whether it is reactive or you are getting atypical lymphoid cells, then you can give a AUS diagnosis, and epithelial cells of unknown or indeterminate origin with bland nuclear morphology. So like in this case, we got few atypical cells in with high NC ratio in MGG. And in pap stain smear, we found only this papilloid cluster. Only one cluster was there, and which was entrapped within blood clots. So morphology is not clear. So we gave a diagnosis of AUS because cell block shown mainly blood. So cellularity was not there in cell block. So we make a diagnosis of AUS in this case, and we can't proceed with the immunocytochemistry. This is another case in which we can see atypical epithelioid looking cells with few binucleation, mildly hyperchromatic nucleoli. And so for this, you can give a diagnosis of AUS, and then you can proceed further for immunocytochemistry. So for this case, BRF4 and MOC31 were negative, and these cells were positive for calretinine. So that's why we can downgraded our diagnosis and given it as negative for malignancy because all these cells are reactive mesothelial cells. The AUS category should be a diagnosis of exclusion, and its rate to be kept as low as possible, and it requires ancillary testing and correlation with biopsy and clinical data. Next category is suspicious for malignancy. So for this category, if you're getting evidence which falls short to confirm a malignancy based on the cytomorphology and ancillary testing, then you can correlate your findings with the clinical and radiological details, and you can perform ancillary testing. So if you are getting small numbers of cells which favors epithelial or other malignancy, but features are not enough to call it frankly malignant, then you can give a preliminary report of suspicious for malignancy, and then you can do immunocytochemistry. So if ICC confirms malignancy, then you can update your report as malignant secondary. And if insufficient representative cells are there or ICC results are equivocal, then you can give a final report of suspicious for malignancy. So criteria are cells occurring in small or occasionally large number, but limited by artifacts. Then monomorphic lymphocytic population, presence of mucinous material suggestive of metastatic mucinous neoplasm, or mesothelial proliferation suspicious for mesothelioma. So this is a 46-year female ascitic fluid we received. There was no relevant clinical history. We got these cells. So there are few clusters and singly dispersed cells. So and cell block was showing similar morphology. So on the basis of these features, we thought of, so our differentials were whether these are reactive mesothelial cells or they are of epithelial origin. So we did mesothelial markers, calretinine, which was negative. Then we did CK20 and CDX2 and CK7, which so CK7 was positive, rest all the markers were negative. Then we went for PAX8, and PAX8 was also positive. So so final diagnosis of malignancy was given, and possibly from a gynecological tract. Now it is very important to define a definitive category, like when to call it AUS and when to call it SFM or suspicious for malignancy, because risk of malignancy and treatment protocol or management protocol is different for both these categories. So there are few certain morphological clues to differentiate both these entities. Like in AUS cases, you'll get mild cytological abnormalities, whereas in SFM cases, greater degree of cytological abnormalities can be seen. Then cell lineage will favor towards benign cell type in AUS cases, whereas in SFM cases, epithelial or other malignant cells of origin are strongly favored. And the implied risk of malignancy for AUS is 20% and for SFM is 80%. So there is a huge difference. So you should always keep these points in mind while making a definitive diagnosis and whether to call it AUS or SFM. The fifth category is malignant. So if you're getting recognizable abnormal cell population and which is adequate for robust diagnosis on the basis of morphology alone, or you can take help of immunocytochemistry markers, then you can make a diagnosis of malignancy. So malignancy can be primary or secondary. Secondary carcinomas, sarcomas, or anything can be there. And if you are giving a diagnosis of malignant secondary, then you should always try to find out the organ site or primary organ site so that management can be planned. So WHO classification of tumor, 5th edition of thoracic tumor, on the basis of which mesothelial tumors are classified into two main categories, localized and diffuse. Both these type of mesothelioma are further subdivided into sarcomatoid, epithelioid, and mesothelioma biphasic type. Both localized and diffuse mesothelioma considered malignant with poor outcome. So malignant primary and malignant secondary. Malignant primary, that is mesothelioma, is a malignant proliferation of the mesodermally derived serosal cells lining the pleura, peritoneum, and pericardium and tunica vaginalis. And it is more common in males than female, highly associated with asbestos exposure, and seen in pleural fluid more commonly than the peritoneal fluid. So definitive criteria for mesothelioma are supercellular smear. You'll get millions of cells even on low power, and numerous cellular spheres, papillary fragments, berry-like morule, single cell, or a mixture of these can be seen. Then in this picture, you can see that cellular smear with numerous clusters and spirules, and cell block is also showing similar morphology, and this is the biopsy sample. So here we can see that cell block closely resemble the morphology of biopsy. So we correlated the biopsy with a tubulopapillary pattern with many collagen cores. So how to identify what are the malignant features? Overt nuclear abnormalities like nuclear enlargement, irregular nuclear membrane, macronucleoli, binucleation, multinucleation, pleomorphism, or atypical mitosis, bizarre looking nuclei you can find. Then presence of numerous large tissue fragment is again in favor of mesothelioma. Other features are pycnotic eosinophilic or orangophilic cells, perinuclear lipid vacuoles, or pink or red granular background on MGG, which represent high hyaluronan concentration in the cases of mesothelioma. Now, if you are sure that is that the case is having proliferation of mesothelial cells, now the question is whether these mesothelial cells are reactive process or it's a malignant mesothelioma. So there are few morphological clues to differentiate, like first of all, cellularity. In malignant mesothelioma, cellularity will be strikingly high. You will get thick matrix background because of the presence of hyaluronan in malignant mesothelioma. Cell population will have wide variation of cell size will be there in mesothelioma. Then you can get inflammatory cells in both the type of lesion. Then size variation again will be variable. So you can get benign, from benign to gigantic cells in the malignant mesothelioma cases. Again, macronucleoli is again in favor of mesothelioma. So as we discussed, multinucleation can be seen in both reactive mesothelial cells also, but mostly in reactive process you'll get 2 to 3 nuclei. Whereas in malignant mesothelioma, nuclei vary from 2 to innumerable numbers. So these are the features. Then you can get 2D clusters are common in reactive mesothelial process, whereas in malignant mesothelioma, predominantly 3D clusters or morules can be there. Now ICC can help. So in difficult cases on morphology, if you're not able to differentiate both these entities, then you can do ICC. So the results are highly controversial, and you can use panel of marker to confirm the process. So these are few markers. So WT1 calretinine D240 and D240 are markers which denotes mesothelial origin. So all these will come positive in both these entities, reactive as well as malignant process. Whereas few markers are there, like if you're getting positivity for Desmin and negativity for EMA, then it is more in favor of a reactive process. And if you're getting Desmin negativity and EMA positivity, then it is in favor of malignant mesothelioma. Ki67 can also help in this determining malignant mesothelioma. So high Ki67 index will be seen in malignant mesothelioma. Now, BAP1 nuclear loss positivity will be there in reactive mesothelioma, but nuclear loss of BAP1 can be seen in 60% of the cases of malignant mesothelioma. Then you can do FISH also for P16 CDKN2A deletion. So in malignant mesothelioma, around 80% cases show homozygous deletion for P16 CDKN2A. So here you can see these mesothelial cells are looking reactive, and we are not sure whether they are reactive or from mesothelioma. So EMA is negative in this case and Desmin is positive. So we can say that these are reactive mesothelial cells. In this case, we can see EMA is diffusely positive in mesothelial cells, and this is Desmin, which is negative. Then we can see reactive mesothelial cells are showing expression of BAP1, whereas this 3D cluster or morule is negative for BAP1, and this is calretinine. So a specific calretinine pattern can be seen in malignant mesothelioma with nuclear and cytoplasmic positivity resembling a fried egg appearance. And this is D240, which highlight the cell membrane of mesothelioma. So all these findings are in favor of malignant mesothelioma. So with the help of morphological clues and immunocytochemistry, you can differentiate both these entities. Now the malignant secondaries. So if they show cytomorphological features either alone or in combination with ancillary studies, the cell type of origin can be epithelial, mesenchymal, germ cell, neuroendocrine, hematolymphoid, or melanoma. Common source of secondary malignant diffusion in adults are, so in male, lung, pleural and pericardial involvement can be seen in lung carcinoma most commonly, and peritoneal involvement is most commonly seen in GI tract carcinomas. For female, breast is the most common primary site, and for pleural and pericardial, and for peritoneal, ovarian secondaries can be there. So adenocarcinoma in vast majority of malignant effusion in adults is the most common type. So a foreign population of cells arranged in small or large rounded 3D clusters, glandular acini formation or signature cell morphology can be there. So here we can see cells are having high NC ratio and large nuclei, variable pleomorphism, and we can see cytoplasmic vacuolization and intracellular mucin is there. And we can demonstrate cytoplasmic mucin with the help of mucicarmin. So this is highlighting the intracellular mucin. In this, we can see that few atypical cells are there, which are showing prominent nucleoli and irregular nuclear membrane. Few bizarre and multinucleated cells are also there. So we gave a diagnosis of suspicious for malignancy in this case, and BUR-F4. Then we did IHC, and BUR-F4 immunostain on the cell block shows epithelial origin of this tumor. So it is important to judicially use the immunocytochemistry panel because you can't cell block because of availability of cell block, you can't choose a wide variety of immunocytochemistry marker to come to a conclusion. So there are few morphological clues on the basis of which you can triage your samples, and then you can go further for immunocytochemistry on the basis of morphology. So if you are getting hollow sphere or cannonball appearance, then it clues towards breast carcinoma. Signet ring cell morphology can be seen in stomach or breast carcinoma. Elongated cells with hyperchromatic nuclei and SNR formation is common, and with individual cell necrosis can be seen in colorectal cancer. Prominent nucleoli with abundant lacy and clear cytoplasm can be seen in clear cell carcinoma metastasis, and small SNR cluster and single uniform tumor cells with large prominent nucleoli is common in prostatic adenocarcinoma. Now, how to determine, how to approach if you are getting tumor cells of different origin. So first of all, morphological features are fundamental to identify a second cell population, and clinical and radiological features are very important. So if patient's clinical information, like you have to see whether what is the if there is history of any malignancy and prior ICC markers have already been done, then morphologically, and you can do immunocytochemistry of prior which was there in primary malignancy, and then if same markers are there, then you can make a diagnosis of metastatic tumor consistent with patient's prior malignancy.
मैम ऑडियो नहीं आ रहा आपका।
Am I audible? Sorry for the inconvenience. There's some technical glitch, I think. I'm not able to share my screen. It is showing host disabled participant screen sharing. Oh, someone from organizing team is here. I can't share my screen. Okay. Okay, so can you see my screen now?
Yes, ma'am.
So sorry. There is some technical glitch. I don't know what is happening. Okay, so now you can get squamous cell carcinoma. So you all know that squamous cell carcinoma, you'll get polygonal shaped cells with orangophilia in the cytoplasm in many cells. Then both benign and malignant squamous cells can show positivity for P40 and P63 and CK56. And malignant squamous cells often stain for P16 in and MC, carcinoembryonic antigen. Then small cell neuroendocrine, you can get cells in clusters and singly scattered with high NC ratio, scant amount of cytoplasm, and stipple chromatin. So you can go further for neuroendocrine marker. And in this case, cyanoptophysin was positive. Then it is important to determine malignant mesothelioma versus carcinoma. So in malignant mesothelioma, atypical cells can mimic secondary origin of cells. So it is important to differentiate both these entities. So for malignant mesothelioma, cellularity will be high. And in metastatic carcinoma, you'll get variable cellularity because of the presence of hyaluronan, thick matrix or thick background can be seen in malignant mesothelioma. Whereas it will be variable in case of metastatic carcinoma, and you can get bloody background or mucin in the cases of mucinous carcinoma. Two type of population will be there in metastatic carcinoma. Then size variation will be, wide variation of cells can be seen in malignant mesothelioma as compared to metastatic carcinomas. Now you can get scallop borders, collagenous core, and hollow clusters, whereas 3D clusters are more common in metastatic carcinoma. You can further go for some special stain to demonstrate the intracellular cytoplasmic mucin. You can use mucicarmin and PAS-T. These are few immunocytochemical markers. So you can use 2 positive and 2 negative markers. So calretinine, D240, WT1, CK56, all these are markers of mesothelial origin. So they will come positive in malignant mesothelioma, except in few cases of few metastatic carcinomas. Then Claudin-4, MOC31, BRF4, B72.3, and CEA. All these are markers for epithelial origin. Now, how to determine mesothelioma versus non-epithelial malignancies? Like for epithelial malignancy, you can do epithelial and mesothelial markers and you can differentiate. But what about non-epithelial malignancies? So non-epithelial malignancies can include melanoma, lymphoma, sarcomas, germ cell tumors, and other pediatric tumors. A relevant history and extensive use of immunocytochemistry can be done. So like in cases of, if you're getting highly cellular smear with monomorphous population of lymphoid cells, then on the basis of morphology and cell size, you can differentiate whether the cells are of small cell type, intermediate cell type, and large cell type. Then you can use various immunophenotyping markers for immunocytochemistry and for immunophenotyping by flow cytometry. So in this case, we can see small sized lymphoid cells and they are showing chromatin can be seen here like football chromatin, and monomorphic population of lymphoid cells is there, which is suggestive of CLL or SLL. Here we can get, we can see monomorphic population of intermediate to large size lymphoid cells showing marked nuclear atypia and few bizarre looking nuclei also there. You can see small mature lymphoid cells in the background. So it is suggestive of a high-grade NHL, maybe Burkitt lymphoma, that you can confirm with immunocytochemistry and further immunophenotyping. Then classical Hodgkin lymphoma. If it is difficult to diagnose a case of classical Hodgkin lymphoma on fluid cytology, if you are getting few singly scattered large atypical cells, binucleated or multinucleated cells in a mixed inflammatory background, then you can think of Hodgkin lymphoma, and then you can do further immunocytochemistry to confirm your diagnosis in a relevant clinical context. Primary effusion lymphomas are quite rare, and there are diffuse large B-cell lymphoma with lymphomatous effusion in pleural, pericardial, and abdominal cavities. And you should differentiate. Differentials are plasmablastic lymphoma, pyrothorax, and associated lymphoma. So here we can see cells, immunoblastic cells with abundant basophilic cytoplasm and prominent nucleoli. Then relevant immunocytochemistry markers are CD30, 38, 138, EMA, etc. Then malignant melanoma, you can, if you are getting cells with large prominent nucleoli and epithelioid, plasmacytoid, or spindle cell morphology, then you can do melanistic marker like Melan H, MB45. You can do SOX10 and S100 also. Now, malignant effusion of mesenchymal origin. So if you are getting cells often present with scant cellularity and tumor cells arranged singly or in loose clusters, and proteinaceous or hemorrhagic background can be there, then you can choose wisely your immunocytochemistry marker panel to make a definitive diagnosis and to find out the cell of origin. Now, we should give a special consideration for peritoneal washing, because in many cases, in many tumors and FIGO staging also, if peritoneal washing involvement is there, then tumor will upgrade. So like ovarian and fallopian tumor upstages to at least AGCC T1C C3 category. And for stomach and pancreas, we can see if peritoneal involvement is there, it is considered as M1 stage or metastatic stage. Cytomorphologically, the cells seen in peritoneal washing can be broadly categorized into benign background element, mesothelial proliferation, benign appearing or low-grade epithelial, or malignant cells with high-grade morphology. So this is an approach. So if you are getting neoplastic resection with peritoneal washing, you should look for morphology, whether the morphology is low-grade or high-grade. If the morphology is low-grade and similar cytological and immunocytochemical findings are there, like the primary neoplasm, then you can give a diagnosis of atypical likely involved by neoplasm. If dissimilar cytology is there, and then you can give a report of negative for malignancy and likely benign. In high-grade morphology, if
मैम आपकी ऑडियो
hello, is it audible now? Am I audible? Anyone?
yes
Okay.
yes
Okay. So, so you can use immunocytochemistry, different type of markers in serous fluid diffusion. Like if you're suspecting mesothelioma, you can go for mesothelial markers, and you should use 1 or 2 epithelial marker to rule out epithelial malignancy. Then for small cell carcinoma, you can do TTF and synaptochromo. For squamous cell carcinoma, you can do P63 and P40. For adenocarcinoma of lung origin, you can go for TTF1. And for ovary, you can do WT1 and Paxil. For breast carcinoma, you can go for GATA3 or mammaglobin. For stomach origin, CK7. For colorectal origin, CK20. And all the germ cell tumors, most of the germ cells tumor will show positivity for SALPOR, and they will be negative for all of the epithelial and mesothelial markers. Lymphoma, you can start with CD45, and then if CD45 is positive, then you can go further on the basis of morphology. Now, certain predictive biomarkers are there that can be used for, like for adenocarcinoma lung, EGFR, L, PD-L1, for breast carcinoma, ERPR, HER2/neu can be done by immunocytochemistry. So cell block is very important for these predictive biomarkers. FISH can also be do to detect homozygous deletion of 9p21. And as per your diagnosis, you can use certain markers. Translocation can be detected by FISH. So there are few markers, predictive markers, immunocytochemistry marker, against which immunotherapy or targeted therapy is available. So you should always try to do these markers so that the treatment can be planned accordingly. Now let's discuss few cases. So here it's a 61-year-old male with history of cough. Here we are getting numerous cells with few morules, and here we are getting few clusters with prominent nucleoli. So on the basis of morphology, what are your differentials? Anyone? No differentials? Okay, so these cells are looking like atypical cells. They could be atypical mesothelial cells in mesothelioma, or they can be from a secondary epithelial carcinoma. So in this case, we gave a preliminary diagnosis of suspicious for malignancy, and then we did immunocytochemistry panel. So in this case, we can see that cellularity is high. We are getting prominent nucleoli, abundant cytoplasm, and scallop cell cluster borders. So all these findings are more in favor of malignant mesothelioma on the basis of morphology. So then we did immunocytochemistry, and here we can see calretinin is positive, EMA is positive, and WT1 was positive. Despin, BRF4, and MOC31 were negative. So on the basis of these immunocytochemical markers, we upgraded our diagnosis and we gave a final diagnosis of, and then yes, we did P16 FISH also. So here we can see P16, this is a normal case in which you can see two signals, red and green, whereas here only green signals are there. So it is suggestive of mesothelioma. So all these findings, along with panel of ICC, P16 deletion was there, and epithelial markers were negative and mesothelial markers were positive. So we upgraded our diagnosis and we gave a final diagnosis with category malignancy, consistent with malignant mesothelioma. This is the second case. Here we can see 43-year-old female with history of shortness of breath, presented with bilateral pleural effusion and pericardial effusion with drain in situ. So here we can see a papilloid fragment and 3D clusters, tightly packed tumor cells are there, and so suggestive of an adenocarcinoma. Now it is important to diagnose what is the primary site. So for which, yeah. So here we can see what are the morphological clues which are in favor of adenocarcinoma: high cellularity, 3D cluster, prominent nucleoli, and scanned cytoplasm. Then we did cell block is showing similar morphology. Then we did mammaglobin and GATA3. Both these markers were positive, so suggestive of origin from a metastatic breast carcinoma. Then we did few predictive markers, HER2/neu, ER, and PR. All these markers were positive. So a final diagnosis, and P16 on FISH, P16, we can see normal signals. So there was no deletion. So a final diagnosis of malignancy and metastatic breast carcinoma was given. Malignancy S, that is malignancy secondary metastatic breast carcinoma. Now, in this case, a 60-year male presented with shortness of breath for 3 weeks with massive pericardial effusion. So we are getting 3D clusters and papilloid clusters. These clusters were positive for TTFN, suggestive of metastatic adenocarcinoma lung. This is another case, 55-year male, lower limb edema, pleural effusion followed by anasarca, and clinical suspicion of disseminated COX was there, and they were not suspecting neoplasm or a carcinoma, but we got tight 3D clusters of malignant cells, and similar clusters were there on cell block preparation. So here we can see positivity for CK7, membranous accentuation. So we gave a diagnosis of metastatic adenocarcinoma. for the first time on pericardial effusion because the clinicians were not suspecting the carcinoma. And then we advised evaluation for primary. This is 17-year male presented with fever, cough, and shortness of breath and hemoptysis for 2 weeks. So here we can see monomorphic population of lymphoid cells are there. And this is a lymphocytic rich atypical lymphoid cells of intermediate size. Then we did CD20 and CD3. CD3 was diffusely positive, whereas CD20 was negative. So we gave a diagnosis, involvement by a T-cell lymphoma, malignant, and then we can ask for immunophenotyping. This is another case of 56-year-old male complaining of chest pain, progressive shortness of breath for 2 months. Right-sided pleural effusion was there with bilateral supraclavicular lymphadenopathy, and there was multiple necrotic lymph node on CT. So we got pericardial fluid for malignant cytology. So here we can see that mostly inflammatory cells are there with few atypical cells with these are few atypical mononuclear and binucleated cells. Here you can see few binucleated cells. So preliminary diagnosis we were given as AUS, atypia of undetermined significance. And we did IHC also to confirm whether these cells are epithelial or mesothelial. So calretinine and WT1 both were negative. So we gave a diagnosis of AUS. Then we got a call from the clinician and they said they are they have a high suspicion of Hodgkin lymphoma in this case. So we did further IHC, we did CD30 and CD30 was positive in these binucleated and mononuclear atypical cells. Then we revised our diagnosis and we gave a final diagnosis of malignancy involvement by Hodgkin lymphoma. Here, this is a known case of prostatic carcinoma, 50-year male, and we got pericardial effusion. So here we can, few atypical cells are there, singly lying in clusters. Cell block is showing similar morphology. So we knew that this patient is known case of prostatic adenocarcinoma. So we did one marker for epithelial origin, where F4 was positive, and a marker, we did a marker, and which was positive. So we gave a diagnosis of METS from a prostatic adenocarcinoma. This is a 49 female abdominal presented with abdominal pain with no relevant history. They were not suspecting any malignancy. We got a cytic fluid. So a cytic fluid cell block ICC was done positive for WT1, P53 and PAX8. So what is this? So we gave a final diagnosis of metastasis from a high-grade serous ovarian carcinoma. Now to summarize, if for serous effusion, first it is very important to assess the adequacy, whether the smears are adequate or inadequate. If smears are inadequate, then you can give a diagnosis, you can report it as non-diagnostic, and then you can advise a repeat sample in relevant clinical context. If the sample is adequate, then you have to see the cellular findings like mesothelial cells or inflammatory cells are there. Then in regard to volume and distribution, if you are getting mostly mesothelial cells arranged singly or in small clusters without any cellular atypia or other findings, then you can report it as negative for malignancy. If the volume is increased and cell distribution is like you are getting predominantly mesothelial cells, numerous clusters and singly scattered, then there are two possibilities, either reactive mesothelial cells or mesothelioma. So here is the use of immunocytochemistry. So on the basis of ICC markers, you can report it as NFM or mesothelioma. If you are getting predominantly histiocytes and no atypical population, then you can go for negative for malignancy. Predominantly lymphocytic population is there, then again, reactive versus lymphoma is a possibility. You should do immunocytochemistry and then immunophenotyping by flow cytometry. Eosinophils, if you are getting without any typical population, you can report it as negative, and neutrophils also you can report it as negative. But if you are getting unexpected cellular and non-cellular findings, then the possibility of secondary metastasis is considered. If single cells are there, then the possibilities are melanoma, lymphoma, breast carcinoma, sarcoma, and you should use your ICC panel wisely to come to a conclusive diagnosis. Small clusters can be seen in adenocarcinoma, breast, lung, and other carcinomas, and large clusters again in adeno, ovarian, and pancreatic carcinoma. And if you're getting all these all these cellular elements, you can report it as negative if you're not getting any atypical cell population. So now the take-home message is the international system serves as a template for improving communication of serous fluid cytology, results that strive to reduce reporting variability. The definitive diagnostic criteria should be kept in mind before making the diagnosis, especially for AUSN, suspicious for malignancy cases, and judicious use of ancillary testing, including immunocytochemistry, FISH, and other molecular testing can help in determining the primary site of malignancy. And AUS should be a diagnosis of exclusion, and its rate be kept as low as possible in order to increase clinicians' confidence in cytological report, reduce patients' anxiety and potential morbidity, and diminish healthcare cost. Thank you so much. So this is my institute, and this is Department of Pathology. I would like to thank all the faculty members, my seniors and juniors from Department of Pathology. So if you have any question, please ask. Yes, so some of you have given your diagnosis, right? Good. Any questions? No questions? Yes, someone is asking something.
मैम क्वेश्चन आपके चैट बॉक्स में ही आएंगे जो आएंगे.
Okay, chat box में तो कुछ भी नहीं है. Okay, I think no questions. Okay, thank you so much. If you have any question, you can mail me anytime. Thank you so much, everyone.
मैम प्रेजेंटेशन स्टार्ट कीजिए
Okay. Fine. So I'll begin. I think someone has unmuted themselves. Yeah. So should I begin?
यस मैम.
Okay. Good afternoon, everyone. At the outset, I would like to thank Dr. Neeraj Jain and his team for giving me the opportunity to talk, for letting me giving this talk. So I'll be talking about approach to cervical cytology, LBC overview. So yeah, so cervical cancer ranks as the second most frequent cancer among women in India. About 5% of women in general population are estimated to harbor cervical HPV 16-18 infection at any given time. And HPV 16-18 are attributed to be causing 83.2% of all invasive cervical cancers. This is the data that has been provided by the World Health Organization, IARC, on cancer. In India, the incidence of cervical cancer significantly rises around the age of 45 years and it peaks at 55 years of age. The natural history of the disease suggests that early diagnosis should initially target those women who have higher prevalence of high-grade precancerous lesions, that is, women who are mostly between the age groups of 30s and 40s. So our screening should focus on these cases. There is no comprehensive national screening program in India at present. A lifetime screening prevalence of 29.8% among women of Indian women has been reported between the age of 30 to 49, which is pretty low, just 29% in women of 30 to 49 years of age. So for every cytopathologist who's doing LBC cytology or cervical cancer screening in conventional way, it is important to know the FOGSI criteria so that you can communicate with your gynecologist better. So as the Federation of Obstetric and Gynecology Societies of India states that in a good resource setting, if one is there practicing in a tertiary care hospital or well-equipped lab, the modalities for screening include HPV testing, which may be upfront primary HPV testing or co-testing, including taking sample for HPV as well as cytology, LBC cytology, or even a VIA, that is visual inspection with acetic acid, can be involved, which is usually used in the limited resource setting. The target age group should be between 25 to 65 years of age, and the screening should begin at 25 years of age. Primary HPV testing or co-testing should be done every 5 years. And if you're doing cytology alone without HPV, then it can be done every 3 years. So what is liquid-based cytology? It is a process by which sample is collected by a broom device, rinsed in a preservative solution. The cell suspension is then evenly distributed as a monolayer on glass slide for better visualization and examination. So just a quick word about how we have progressed, why we are progressing towards LBC preparation over the conventional pap smears. So in the conventional pap smears, more than 80% of the cells are lost. 100% of the cell transfer occurs in LBC preparation because the brushings are rinsed in a liquid solution, which I will be detailing further. Cell fixation is variable in conventional preparation, while it is uniform in LBC. Distribution is heterogeneous in conventional, why it is homogeneous, monolayered in LBC preparation. Preservation is variable, again, because of the cell distribution. In conventional, it is diffuse and well preserved in LBC smears. Cellular analysis is difficult in conventional smears at times because there are multiple thick, uneven groupings and need frequent focusing. That is not the case in LBC preparation. Cells screened at any given time in a conventional smear is roughly around 300 to 550,000, 300,000 to 50,000 cells per slide, while those screened in LBC preparation are equivalent or even slightly more. Background dirt, mucus, debris is often a confounding factor in reporting in conventional preparations, while it is clean in LBC smears. Screening time is tedious and time consuming in conventional preparations and causes a major concern in high throughput centers, while it is markedly reduced in LBC preparations up to 5 minutes. Now, coming on to ancillary investigations, they cannot be done on conventional preparations, while the main forte of advantage in LBC preparation is the sample can be subjected to repeat testing, HPV analysis, IHC, and even cell block preparation. So the benefit of conventional over LBC is it is cost effective, that it is 500 to 800 rupees per test, while in LBC preparation in our setup, we charge around 1,000 to 1,400 rupees per case. Now, coming on to the available platforms of liquid-based cytology screening that are US FDA approved. Several platforms are available in the market. However, SurePath and ThinPrep are the most popular ones and are US FDA approved. SurePath has been developed by BD and it works on the principle of density gradient and gravity sedimentation. ThinPrep is developed by Hologic and it works on the principle of filtration and collection of cells on a vacuum packed membrane and transferring it to slide. Monoprep PAP has also been approved by US FDA. However, it is not very popular in our country. It still is used at places in the UK. It is based on alcohol-based fixative with a proprietary vial and stirrer, and they use a suction method that transfers the smears, the material on the slide. As I mentioned, several indigenous screening techniques have been developed, like WellPrep, TubbyTac, CellSite, PapSpin, and Cytoscreen, but these have not been approved by US FDA and are being used in small setups only under research. So coming on to the what is the basic principle of SurePath that is very popular and which I am using in my lab routinely. So for SurePath, Sample is collected via a Cervirex brush. A spatula can also be used. The spatula is rotated about 10 times in a clockwise direction at this cervical ecto and endocervical junction and the cervical lips, and it is dipped. The tip of the brush is not exactly broken. It is removed from the tip head. It is removable, and it is put in a ethanol based fixative, that is cyto-rich. So the machine then, it's a fully automated machine that is there in the BD SurePath. So it works on the principle, there is a prep made which has a syringe which enters directly into the vial and has a quick rinsing action to mix the homogeneously mix the sample. The sample is then transferred into a tube in which density gradient density gradient reagent is added. The density gradient reagent is made up of neutral polysaccharide with azide fixative, so that it provides a neutral environment to the cells and they are not lysed. Then coming on, this step is followed by centrifugation, which goes under 2 steps. In centrifugation, the supernatant is initially discarded by, again, an automated method. Then there is an enriched layer, and then there is a diagnostic material. The enriched layer is decanted, and it is the pellet that is entered into the tripath prep stain, which is then made into a SurePath monolayer preparation on the slide. This is the workflow that we have in the lab. These are the kind of vials which have a volume of 10 ml are provided. And in this solution, the head of the Cervex brush is left out. As I mentioned, 10 times rotation of the brush is carried at the os. This is the tip head that is left behind. The vortexing is very essential before starting a processing of the sample, and as well as after the supernatant is to be discarded. Before that, this is the prep made gradient machine in which this mixing is carried out, centrifuge, and finally the automated stain provider, automated slide stainer. So the BD SurePath machine is a closed system which uses the proprietary materials provided by the company itself. Now coming on to the thin prep, which we are not using, but it has a similar interesting principle. The spatula that is used to take the cervical sample is rinsed into the thin prep vial. The head is not broken, it is just rinsed vigorously. So after that, the vial is entered into an automated system provided by Hologic. The principle of thin prep is that there is a disposable suction machine that is there. It is fitted with a neutral polysaccharide filter. The filter membrane has pores of 8 microns, so it filters out all debris, necrosis, and hemorrhagic material. There are 3 basic principles. The filter moves up and down and provides with a current and provides cells linear flow in a current, so that there is adequate mixing and dispersion of the cells. A gentle vacuum is created and the cells are pulled up under the vacuum effect onto the membrane. This membrane is then rotated 180 degrees, and the impression of the cell, the filter is then taken on the slide, hence creating a round monolayer circle of 20 mm on the slides. So the difference between SurePath and thin prep, the principle, as I said, cell enrichment in SurePath, while filtration and collection under vacuum of packed cells on a membrane in thin prep. Fixative use in SurePath is ethanol, while that is cyto-rich fluid. In thin prep, it is cyto-light. Sample collection, again, broom head is rinsed vigorously and broken off in SurePath, while in thin prep, it is it's written opposite over here. Sample preparation, vortexing is essential step in SurePath, while no vortexing is carried out in thin prep. The screening area is smaller in SurePath, about 13 mm, while in thin prep, it is larger, about 20 mm. Now, the shelf life of residual fluid, if one intends to do an HPV or even do ancillary testing, can be done up to 3 weeks in the residual fluid in SurePath, while it can be done up to 3 months in thin prep at room temperature. So which is an added advantage. Now coming on to the slide interpretation. So I would like to highlight over here, this is a low power view. I've tried to show how the slide should be screened. It's like a crisscross battlefield pattern. One should move in a single direction at a time, so that all fields are covered. And once the slide is covered in the horizontal direction, we now carry the vertical direction so that all the fields are covered. For beginners, at 40x, screening should be done with confidence till the confidence in morphology and interpretation is observed. It can later on be switched to 20x. Overlaps in the screening fields is good to occur, so that you may be screening more thoroughly, but no field is left behind, so that focal lesions are not missed. Adequacy for sure path is 7 to 8 cells per high power field for fulfilling the criteria of 5,000 cells visualized, well-preserved squamous and squamous metaplastic cells. For thin prep, it is 3 to 5 cells. So in cases of patients who are undergone radiation post-therapy or post-menopausal female with severely atrophic or stenotic cervical canals, the sample adequacy can be reduced from 5,000 to 2,000, and it is acceptable. Now coming on to the most common NILM lesion, that is negative for intraepithelial lesion or malignancy. This is the monolayer preparation that we see on LBC. This picture shows predominantly superficial squamous cells. The cervical epithelium is composed of basal, parabasal, intermediate, and superficial cells. Cells achieve the superficial status or maturity under the effect of estrogen. Estrogen is there in the first half of the menstrual cycle, that is the follicular phase. So superficial squamous cells, as we can see over here, they have abundant cytoplasm and a pycnotic dot-like India ink nucleus that is characteristic of mature squamous cells. Now coming on to the next cell type, that is the intermediate squamous cells. One thing I'd like to mention, that the superficial squamous cells it is not the pink cells that are superficial. The keratinoids and non-keratinoid cells both can be superficial squamous cell. It is the nature of the nucleus and the chromatin that decides whether the cell is superficial or not. Coming on to the intermediate squamous cells, under the effect of progesterone, the vaginal epithelium matures from the parabasal to the intermediate cells. Cells of intermediate cell size have nuclear larger than the superficial squamous cells, and as we can see here, they're often elongated and have a groove in the center. So when do we see most common, when do the intermediate squamous cells predominate in the smear? When the cells are under the effect of progesterone. That is also like in pregnancy. Even if a newborn girl's vagina is sampled, it will show predominant intermediate cells that is under the effect of maternal transplacental effect of hormones. Now, parabasal squamous cells, as seen in this slide, they are usually rounded. They acquire squamous feature from the basal epithelium. They have a dense cytoplasm and distinct cell boundaries and have a higher NC ratio as compared to the superficial and intermediate squamous cells. They predominate in atrophy and postpartum stage. They're usually not sampled in premenopausal women, and they may be confused with metaplastic squamous cells. However, if you're seeing cells like these in the premenopausal female with inflammation, they are likely metaplastic. Now, coming on to the other cells that we see, these are the honeycomb sheets of endocervical cells, the picket fencing appearance with tall columnar nature and abundant mucin. The endometrial cell groups, this is the typical exodus of shedding endometrium seen in the initial 6 to 10 days. There is a peripheral rim of endocervical cells and a central endometrial stroma. The endometrial cells, classically, they are smaller in size than the endometrial cells. They have a denser chromatin and scant cytoplasm. At times, they may appear as bare nuclei also because the cytoplasm undergoes degenerative changes. Presence of endometrial cells up to first 12 days of menstrual cycle is normal and is taken within normal shedding. And presence of endometrial cells beyond 45 years of age should be reported in your LBC reporting as per Bethesda. So now next, coming on to the inflammatory smear, which is the most common pathology that we see. It is NILM. It is negative for any lesion, but it is inflammatory. So when assessing inflammatory smears, one should always screen for organisms that the cause of inflammation, which may be due to organism or an intraepithelial lesion, an IUD in place, or reactive changes occurring post-therapy. So a quick word about the most common organism that are encountered in LBC. That is the pseudo-hyphae or budding yeast form of Candida. This is the classical spearing effect of Candida hyphae. When they bud, they spear through the squamous cells and they appear classically in the LBC like this. It is only either the presence of pseudo-hyphae or budding yeast form. Both are taken as positive for Candida. Now coming on to Trichomonas vaginalis. Unlike the conventional LBC, the background may be clean unlike the conventional preparations, background may be clean in LBC preparation of Trichomonas vaginalis. What catches one's eye, when should you suspect Trichomonas vaginalis? The patient might be complaining of itching in the vagina or itching in the perineum. And when you put the slide even in the low power, you can appreciate this faint degenerate kind of cells that is there. This is known as a trick change. For beginners, they may think it to be perinuclear cholestatic kind of change, but there is only a thin rim of clearing around the nucleus. That is the trick change, secondary change to caused by the organism. And this is the classical pear-shaped organism, Trichomonas vaginalis, also seen over here. They have a slit-like Mongol's eye nucleus and fine granular cytoplasm. Flagella is also often seen in the liquid-based preparations. Coming on to the next organism, that is Actinomycetes. These are woolly organism, filamentous bacteria commonly associated with IUD. What is important is they are often confused with bacterial colonies, and they can pose a challenge at times. It is important to analyze that bacterial colonies, as seen in this high power, will show you fine threads, and their morphology and bacteria will also be seen in the background. So one can match the morphology of these woolly organisms with the surrounding structures. If you see thin threads like this in the background, this is likely bacilli and not the Actinomycetes. Now, coming on to another organism, which we think that not so common, but at least they frequently poses a diagnostic surprise in routine LBC screening, that is amoebic trophozoites. Patient will come to you with foul-smelling discharge or even a friable growth, and the gynecologist will suspect it to be a malignancy. But these organisms, this is a 40x view, you can see they mimic histiocytes. They have a, but how do they differ from histiocytes? They have a well-defined cytoplasm. You can see RBCs that are erythrophagocytosis in the cytoplasm. You can see a eccentrically placed nucleus, and there is a central dot which is reminiscent of a central karyosome. That is characteristic of an amoebic trophozoite. One should know how to pick up amoebic trophozoites because the treatment is immediate. Patient becomes okay within a week as compared to a grave diagnosis of a malignancy. So now coming on to the intraepithelial lesions, that starting from ascus. So ascus is nothing but when we see atypia in the squamous cells, that is qualitatively or quantitatively not amounting to a L cell. So the nucleus, as we can see here, it is 2.5 to 3 times that of intermediate squamous cells. The nuclear enlargement is the first step towards suspecting an ascus, followed by nuclear changes. What I mean to say is, you might see subtle membrane irregularity, hyperchromasia, and few of the squamous cells. However, if the nucleus is not enlarged, do not think of an ascus. For labeling anything as an ascus, nucleus has to be enlarged at least 2.5 times of that of intermediate squamous cells. And also, you cannot go on randomly giving out ascus in your report. Few of my junior colleagues and people from outside had asked me, why not give benefit to the patient and give a diagnosis of ascus? No, so you will end up writing up more and more ascus, which is bad for your lab, because as a part of internal quality check, for every cell you diagnose, there should not be more than 3 ascus reported in your reporting. That is required for NABL credit accreditation. So ascus cell ratio should be less than 3:1. And ascus diagnosis should always be followed by a high-risk HPV DNA testing so that unnecessary anxiety is avoided to the patient. Coming on to L cell. So L cells corroborate with SYN1 in biopsy and is indicative of HPV infection. It is observed in superficial and intermediate squamous cells. As we can see, the cells are significantly increased in size. The nuclei are about more than 3 times the size of an intermediate squamous cells. As you can see, this is a classical coilocyte where there is perinuclear clearing with cleared out cytoplasm and dense nuclear membrane. That is the viral cytopathic effect of a coilocyte. Coilocytes may be bi or multinucleate. However, presence of a coilocyte is not required for a diagnosis of L cell. Nucleus membrane irregularity more than 3 times, hyperchromasia, irregular chromatin distribution also warrants a diagnosis of L cell. So polycytic change is nothing but a perinuclear cavitation that is seen in the cytopathic effect as a part of the cytopathic effect. Now coming on to ASCH and HCL. So ASCH and HCL cells are smaller cells. They're much smaller than the L cell cells. This and ASCH is diagnosed when the cellular criteria is qualitatively or quantitatively less than that of HCL. So when you may see an ASCH in a background of an L cell, where an ASCH is picked up when you see occasional small cells with high ANC ratio and irregular membrane distribution and irregular chromatin distribution. So when you don't see syncytial groups or sufficient number of cells, it is better to give a diagnosis of ASCH. For L cell, you see cells are smaller, have high answer ratio. There are various patterns of H cell. The cells may be seen in syncytial aggregates, hyperchromatic crowded groups, or even in sheets. Nuclei are generally hyperchromatic, and cell cytoplasm may be dense, as you can see in this group also. The cytoplasm is dense, or we can say immature. Every H cell diagnosis has to be followed by a colposcopic guided biopsy, so that we are not missing on an underlying invasive carcinoma. So now coming on to the next group, that is squamous cell carcinoma, which is the gravest of all diagnoses. In squamous cell carcinoma, one has to appreciate a variety of nuclear forms, as is seen in this picture. This is a smear of a probably an atrophic female, where we see the cells have high MC ratio. There is irregularity of the cells. Cells are showing tadpoling tailing. There is tailing of the cells. There are few strap cells over here. The nuclei are showing pleomorphism, irregular chromatin, and there is evidence of diathesis. Diathesis in the form of necrosis, fibrin debris. It is so in LBC preparation, the classical dirty background is not seen, as because it's a liquid-based preparation. It is washed off. The filters wash off the background debris. But with a good eye, you can pick up focal clinging diathesis, also fibrin debris, which is seen between the cell groups. And marked pleomorphism, as we are seeing here. Occasional mitosis can also be seen. So when you see diathesis, you should, in conjunction with clinical picture, a diagnosis of SCC is warranted upfront. But in the absence of diathesis, and if there is no growth, it is better to give a diagnosis of HCL with features suspicious of invasion, so that the clinician might go for a subsequent biopsy to look for an invasive carcinoma. It still may be an HCL. Coming on to the next, the glandular lesions. So there's a separate entity of atypical glandular lesions, atypical glandular cells, which may fall into NOS or favor neoplasia. So one should make an attempt in deciding the origin of glandular cells. However, if there is any ambiguity, it's no hard fast you give it a diagnosis of AEC, that is atypical endocervical cells or atypical endometrial cells. It is better to give a diagnosis of AGC, that is a broad umbrella of AGC, and not misdiagnose, so then adequate endocervical and endometrial workup can be done. So this is the figure A, in which we see I picked up this case because we can see these are atypical endocervical cells. The cells are appearing elongated, somewhat columnar in configuration. The nuclei are budding off. They are eccentric. They're coming out of the cytoplasm. That is known as the characteristic egg and snake appearance. That is a snake with an egg bulging out. You can see over here, the nuclei are bulging out. So this is the characteristic egg and snake appearance. And the smear also had occasional groups like this. So we gave a diagnosis of atypical endocervical cells favor neoplasia. And this patient turned out to be an endocervical adenocarcinoma. Coming on to another case. So this, for an untrained eye, will appear to be as an inflammatory smear. But if you see carefully, there are these polybags over here. There are these cells which have eccentrically placed enlarged nucleus. The chromatin is vesicular and polymorphs are going within. So this is a smear of a postmenopausal lady with polybags seen in these large vacuolated cells, which is very suspicious. This is these are endometrial cells with polymorphs going within. So this is atypical. These are atypical endometrial cells, and we gave a diagnosis of atypical endometrial cells favor neoplasia. And on follow-up biopsy, it turned out to be endometrial carcinoma, adenocarcinoma grade 2. So to conclude, it is imperative to be well versed with the cytomorphology of cervical lesions to catch the disease early in the course. Screening well done is a malignancy sabotaged. All women in reproductive age group must undergo HPV vaccination. So LBC evaluation with HPV co or reflex testing. So the government of India has now proposed HPV vaccination in all females of 9 to 14 years of age so that the disease does not set in. It is preventive in nature, but it is yet to be accepted in the national immunization program. Thank you. I'll be happy to take any questions. So there is a question in the chat box: how to differentiate coilocytes from pseudocoilocytes. So I would like to highlight that coilocytes have pseudocoilocytes you can see in a lot of conditions: glycogenation, secondary to infection, secondary to inflammatory conditions. For a coilocyte, the cytoplasm has to be dense. There is not a thin rim of clearing. There is a classical washed out appearance of the cytoplasm. Very clear, transparent cytoplasm over a wide area around the nucleus, and the rim of the cytoplasm is dense. It is concentrated at the periphery. While in pseudocoilocytes, there is a very thin rim of clearing. The cytoplasm, it is not transparent. It is not clear. You can see through, and there is no dense rim. The cytopathic effect of the virus is not setting in. So that is how you differentiate a pseudocoilocyte. So another question, atrophic smear from malignancy. Yeah, see, so your threshold for diagnosing malignancy in atrophic patients has to be really high as compared to our reproductive age patients. Atrophic smears, when you're diagnosing malignancy in atrophic patient, the threshold has to be high because the parabasal cells are smaller. The cytoplasm again is denser, but it is the nuclear characteristic which will help you in guiding towards atypia in patients who are postmenopausal. Nuclear membrane irregularity is the single most criteria which is sure shot of picking up a malignancy. Nuclear membrane irregularity, this is the first thing, followed by irregular chromatin distribution and nuclear folding. So if you don't see that, it is better you favor an atrophic smear than for a malignancy. Also, one more point: if there is still an ambiguity, you're not sure that it is a typical parabasal or there is an atypia. So that there is one practice which we do at times when there is real ambiguity between atrophy versus malignancy. It is advised that you write a note in your LBC report later on at the bottom that if few atypical cells are seen, an estrogenization of the cervix is advised, followed by a repeat pap smear. So as I mentioned, for maturation of the pap smear, for maturation of the cervical cells, estrogen is required. So once the gynecologist reads the note, she gives estrogen cream to the patient for a week. The cells under the effect of estrogen, they mature. So the parabasal cells, which were looking atypical, when they start maturing, either the atypia that you were suspecting will outgo and the cells will be mature, or if there is a true cell over there, the cells will be highlighted and the cells will mature and you will be picking up an H cell or an L cell straight away. That's it. Any more questions? I think there is no other question in the chat box. Thank you for your comments. I'll be happy to take any questions later on. You can write a mail to me also, pujanagarwal@gmail.com. It goes with my name also, anytime. I think with the organizers,
Okay, ma'am. Thank you.
okay, thank you.
Hello, am I audible?
Yes, ma'am.
Okay. So, good afternoon, everyone. My topic for today is podocytopathies. I am Dr. Anisha Manocha, and I am a consultant pathologist at Max Super Specialty Hospital, Saket. So, let's start with the topic. If we look at the picture here, I'll just put on my pointer. This is what a podocyte looks like on an electron microscopy. So if we look at the picture here, this is the cell body of the podocyte, and here we have the food processes of the podocytes. These are we can see these cell bodies extending and forming these food processes which go and attach onto the GBM or the glomerular basement membrane. And this structure together forms the filtration barrier. So the filtration barrier is formed of three structures. First is the slit diaphragm, which is present between the food process of the podocytes. Second is the glomerular basement membrane. And third are these endothelial cells, which are present over here. Now, when the entire blood of the body is passing through these tiny capillary walls, what happens is that it will create a certain amount of pressure, or a shear stress will be formed. And as a result of the shear stress, this blood gets filtered out. So if we look at the schematic diagram also, here we can see again these food processes of podocytes, and in between these food process, we have the slit diaphragm over here. Here underneath is the glomerular basement membrane, and these red structures here are the endothelial cells. So these three things together, the slit diaphragm, the glomerular basement membrane, and the endothelium together will form again what is known as the filtration barrier. Now, normally what happens is we have protein molecules or albumin molecules which are negatively charged. And we have these endothelial cells which are coated with glycocalyx, which is also negatively charged. So if the protein tries to escape, the negative charges will repel each other, and this protein is pushed back into the circulation. What happens in case of a podocytopathy is that you have effacement of these food processes, and these slit diaphragms are lost. The other thing that happens is that the negative charge on these endothelial cells is also lost. So the protein gets a free passage. And as a result, in case of podocytopathies, this protein gets lost in the urine, resulting in proteinuria. Because it is lost in the urine, it will result in hypoalbuminemia. There'll be decreased oncotic pressure, because of which the body will try and retain sodium and water, and that will result in edema. And also the liver will start increasing its lipid production, which will result in dyslipidemia. And all these things together will constitute what is known as the nephrotic syndrome. So we know what nephrotic syndrome is clinically, but what do we see in pathology? Nephrotic syndrome is nothing but diffuse simplification, effacement, or fusion of the food processes of the glomerular visceral epithelial cells, and focal detachment from the glomerular basement membrane. So here also, if we look, this is a normal healthy podocyte where you can see the cell body and you can see these food processes. Here again, you can see these food processes. Whereas in a diseased condition, we can see that the entire podocyte is effaced, and you cannot make out any food process over here. So again, if you see, this is a normal healthy podocyte. Cell body is here, and it is extending and forming these podocytes, these food processes. Every alternate food process comes from one particular podocyte, and that is how you have interdigitating of these food processes. But in a diseased condition, we can see that we cannot make out any structure, and this has formed one big mass over here. And just above the glomerular basement membrane, we can see these electron dense structures here, which is nothing but your condensed actin. So how do we classify podocytopathies? First is, there are two ways in which we can do it. One is whether it is genetic or acquired, and the other thing is whether there is a diffuse food process effacement or there is a focal food process effacement. So if we first look at the genetic podocytopathies, the diffuse genetic podocytopathies tend to have a very early onset. Usually, most commonly, it is within the first 3 months of life, or at least within the first year of life. And the focal genetic podocytopathies have a later onset with progressive proteinuria. So what are the mutations which cause nephrotic syndrome in the first year of life? So the first one and the most common one is NPHS1, which codes for protein nephrin, and this causes congenital nephrotic syndrome of the Finnish type. Second is your NPHS2, which codes for podocin, and this results in an FSGS. And apart from that, we have these three, that is PLCE1, LAM2, and WT1. And all of these three cause what is known as DMS, or diffuse mesangial sclerosis. The other thing to note is that all of these are autosomal recessive. The only one which has an autosomal dominant inheritance is this WT1. So we'll discuss some of the genetic podocytopathies. The first one is the congenital nephrotic syndrome of the Finnish type. Why is it called Finnish type? Because it was discovered in Finland. These patients, they present at less than 3 months of age, and there are two major types. First is the Finn major, which have an earlier onset and they have a more rapid course. And second is the Finn minor, which have a later onset and a delayed progression. So what do we see on microscopy? First is we will see a fairly normal looking glomerulus, except for a slight increase in mesangial cellularity. Also, the podocytes here are very prominent. But other than that, we are not seeing anything else in the glomerulus. They are fairly normal, just the cellularity is a little increased. The other thing is you have this microcystic dilatation of the tubules that is present. On immunofluorescence, the routine panel that we do of 3 immunoglobulins, 2 complements, those are all, of course, negative. But if we stain for nephrin, normally nephrin is present in the glomerulus in the slit diaphragms, and it will show up in the staining. But in these patients, this nephrin staining will be absent. If we look at the electron microscopy, we can see that these are again the podocyte foot processes, but the slit diaphragms over here are absent. If we see the schematic diagram, we can see that these slit diaphragms are made up of a number of proteins, one of which is nephrin. And because this nephrin is not there, these slit diaphragms do not form, and we can see the absence of these slit diaphragms on electron microscopy. The second one is podocin deficiency. Podocin deficiency will cause familial FSGS, and on light microscopy, you will have a perihilar segment of sclerosis. Again, like in the previous condition, in a normal glomerulus, podocin staining will be present, but in these patients, this podocin staining will be absent. And again, on electron microscopy, you will have effacement of the food processes. The third one is diffuse mesangial sclerosis. There are a number of genetic mutations which can cause this disease. These patients present at less than 2 years of age, and they have a progression to end-stage renal disease, usually by 3 years. They are associated with various syndromes like Dennis-Drash, Frazier, and Pearson syndrome. On light microscopy, we will see this solidified sort of glomerulus with proliferation of these overlying podocytes. So here again, if we see, the glomerular tuft is all sclerosed and shrunken, and these podocytes on top are proliferating. Sometimes these proliferating podocytes can look like a pseudo crescent, and it can be difficult for an untrained eye to differentiate between a crescentic glomerulonephritis and a DMS. So in such cases, we can do a WT1 staining, which will stain these podocytes, and we know that this is a podocyte proliferation and not a crescent. Again, on electron microscopy, we will have food process effacement and podocyte detachment. Then we have the ApoL1 related glomerular diseases, which has been talked about quite a bit. So ApoL1, as we know, there are two risk alleles, G1 and G2, and they are most commonly seen in the African American patients. And kidneys which have two ApoL1 variants have a 2-time increased risk of allograft failure. Now, how does it present? There is a spectrum in the light microscopy that we see. First is we can see this sort of a collapsing glomerulopathy. That is, we can see the shrunken tuft of the glomerulus, and we have proliferation of these overlying podocytes. So this is a collapsing glomerulopathy. We can also have an FSGS sort of picture. The tubulointerstitium will show this microcystic dilatation again of these tubules. Here also we can see these dilated tubules along with this interstitial fibrosis and inflammation. And the other thing that we can see in an ApoL1 related glomerulopathy is a hypertension like chronic kidney disease like picture. So we will have this solidified sclerosis of the glomerulus, and the vessel changes will be similar to what we see in hypertension, where we have hyalinosis, onion skinning, and fibrointimal hyperplasia. So there are various mutations which can be seen in FSGS, and whenever we are thinking of a genetic cause of FSGS, we have to test for these mutations. But there is one other thing that we must keep in mind. So if we look at this paper where they have done genetic testing for their patients with FSGS, they have found that the genetic diagnostic rate was about 11%, and the most common mutation that they found was collagen 4A mutation, which is responsible for causing your Alport syndrome or thin basement membrane disease. So if we are seeing an FSGS like picture, we should not forget to test for this gene as well, because this patient might just have an underlying Alport syndrome. So how do we approach a case of FSGS? We have to basically look at three things. First is whether the patient clinically has a nephrotic syndrome or not. First. Second thing is we have to see the food process effacement, whether it is diffuse or segmental. And the third thing is if we are suspecting a secondary FSGS, whether there is any secondary cause for that FSGS or not. So, in the first condition, in the first scenario, if the patient has nephrotic syndrome and has a diffuse food process effacement, we know that we are dealing with an FSGS. So, we will start the therapy for this patient and see if he is responsive or not. If the patient responds, we know that we are dealing with a primary FSGS. If the patient is resistant to therapy, then we go ahead with genetic testing. The second scenario is when the patient does not have nephrotic syndrome but has a diffuse food process effacement. And in this condition, we will go ahead with the genetic testing. The third and the fourth scenario is when the patient has a segmental food process effacement. So clinically, whether there is a nephrotic syndrome or no nephrotic syndrome, and there is a segmental food process effacement, but we are not finding any proper cause for a secondary FSGS. In such conditions, again, we go ahead with the genetic testing. And in the fourth scenario, where there is segmental food process effacement, but we have a secondary cause for the FSGS, then we are dealing with a secondary FSGS. So that finishes with the genetic podocytopathies, and then we move on to the acquired podocytopathies, which can again be either diffuse or focal. And this is what we see more commonly in our routine practice. Again, diffuse acquired podocytopathies will have a very sudden onset nephrotic syndrome, whereas focal ones will have progressive proteinuria and CKD. So our usual minimal change, primary FSGS, membranous will all come under a diffuse acquired podocytopathy. And again, this is the EM picture here where we can see the food process effacement. We can see this actin condensation. We can see detachment of these podocytes, which is, when we see this, we know we are dealing with a podocytopathy. So in a minimal change disease, there are certain things that we have to be mindful of. So supposing a minimal change disease has come with a raised creatinine, it does not rule out the possibility that we are dealing with with an MCD. We have to look for a cause for the raised creatinine as well. So there are two things that can be present. First is it could be a minimal change with acute tubular injury, where here again we can see we have dilated tubules, we have loss of brush border and a flattened lining epithelium. The other cause of minimal change disease with raised creatinine is an ATIN. That is, you have this interstitial widening with an inflammatory infiltrate consisting of eosinophils as well. So if we have a raised creatinine with minimal change, there are two other things most commonly which we look for. One is ATI, the other one is ATIN. What are the clinical conditions which are associated with minimal change disease? First is drug use. Second is early stages of HIVAN, collapsing glomerulonephritis or heroin nephropathy. And we have certain malignancies which are associated like Hodgkin's, CLL, or other lymphoproliferative disorders. We can have certain allergies like insect bites or immunizations. And then there are certain other glomerulopathies like IgA nephropathy, SLE, diabetes, which can also be associated with a minimal change disease. So supposing we have a case of diabetic nephropathy where we are not seeing very frank changes of diabetic nephropathy, maybe it is just a class 2 diabetes on the biopsy, but the patient has presented with a very high proteinuria, say 10 grams. So in other words, the class of the diabetic nephropathy is not correlating with the amount of proteinuria. In such cases, we have to think of an associated podocytopathy, or maybe there is an associated minimal change disease, and alert the clinician accordingly. Coming to FSGS, we have a morphological classification of FSGS, which consists of a perihilar variant, which is most commonly seen in adaptive or obesity-related FSGS. Second is the tip lesion. Third is the collapsing FSGS, and fourth is the cellular FSGS. If none of these, if the lesion does not fit into any of these, we classify it into FSGS of not otherwise specified. But this morphological classification is currently not being used because it doesn't have a lot of clinical significance. But I will still show certain pictures which will give some clarity as to what they are. So here, if we see, this is a tip lesion. In this glomerulus, you have a hilar pole and you have a tubular pole. And here the glomerulus is opening into this tubule. And over here, there is a segment of sclerosis. So at the tubular pole, in the outer 25% of the diameter of the glomerulus, we are seeing this sclerosis, the segment of sclerosis. This is nothing but your tip lesion. And it is important to identify this. Why? Because these tip lesions have a very good prognosis and they are responsive to therapy. They behave like a minimal change disease. Second is this perihilar sort of segmental sclerosis. Perihilar segmental sclerosis most commonly is seen in cases of secondary FSGS, where it can be secondary to hypertension, obesity, etc. Third is this collapsing type of FSGS, where again we can see that there is a collapse of the tuft. We cannot see these capillary loops very clearly. They are all collapsed and they are stuck together. And if you see outside this, you have proliferation of these podocytes, which are going almost inside here. So this is a collapsing GN. On IF will be negative. Only sometimes IgM and C3, being big molecules, they can adhere onto the surface of the segmental sclerosis, but these are not true immune deposits, and we can mention it in our report, but it does not change the diagnosis in any way. It's just a pointer that can help you pick up the segmental sclerosis. Again, on electron microscopy, what we will see in case of a primary FSGS is we will see a diffuse foot process effacement where almost 75% of the podocytes are effaced. If we have less than 50% effacement, we can think of a secondary FSGS. There are certain permeability factors in case of podocytopathies. We have the first one is CLC1, which is elevated in a recurrent FSGS, SUPAR, which is also elevated in FSGS. And then we have angiopoietin like type 4, CD80 and IL-13, which are elevated in a minimal change disease. FSGS has an early recurrence post-transplant and it can recur as early as 3 months, and the recurrence rate is 20 to 45%. So I've already talked about the morphological classification of FSGS, but it is a better way of classifying FSGS is the pathophysiological classification. which is more commonly being used and is more helpful to the clinician. So the first one is an idiopathic or a primary FSGS. Second is a secondary or an adaptive FSGS. Third is a segmental glomerular scarring. And fourth is a familial FSGS or autosomal recessive genetic podocytopathies. So we've already discussed the primary type of FSGS. Coming to the secondary, or the other name for that is adaptive FSGS. So adaptive FSGS can be of two types depending on the pathophysiology. First is conditions in which there is an initial loss of the functioning nephrons, and these include conditions like unilateral renal agenesis, segmental hypoplasia or oligomeganephronia, unilateral renal dysplasia, reflux nephropathy, patchy cortical necrosis, where for some reason or the other, a part of the kidney is not functioning properly. Because one part is not functioning, the other part of the kidney has to compensate for that part. And that is how the size of the glomeruli begin to increase. If the size of the glomerulus increases, there is a certain shear stress which is caused on the podocytes, and because of that shear stress, the podocytes tend to get detached from the glomerular basement membrane. Where the podocytes detach from the basement membrane, that part will go and adhere to the overlying Bowman's capsule, and that forms a nidus for the segmental sclerosis. That forms a synechia, and that synechia will form a nidus for the segmental sclerosis. The second condition where an adaptive FSGS can occur is where there is where conditions where without an initial loss of nephrons, but there are functional maladaptations. So because of certain functional reasons, there is no part of the kidney that is lost or not functioning, but because of certain functional reasons, the kidney is not able to function normally. So the first one is diabetic nephropathy, second is familial dysautonomia, third is obesity associated proteinuria or metabolic syndrome. Out of this obesity associated proteinuria is the one which we see most commonly. So how do we differentiate between an idiopathic primary versus a adaptive secondary FSGS? So an idiopathic primary FSGS will have a sudden onset nephrotic syndrome with edema, whereas an adaptive FSGS will be a very slow process, a slowly progressive proteinuria, and edema is usually not the presenting feature. In a primary FSGS, there will be no history of prior kidney disease, whereas in an adaptive adaptive FSGS, there will be history of prior kidney disease, like maybe a diabetes or a hypertension, etc. In idiopathic FSGS, the glomerulus will be normal sized, whereas in an adaptive FSGS, you will have glomerular hypertrophy. So whenever we are seeing this glomerular hypertrophy, it should alert us to the possibility of a secondary FSGS. And lastly, like I said, in an idiopathic FSGS, there will be diffuse effacement of the food processes. That is more than 75%. At least more than 50% of the food process should be effaced. Whereas in an adaptive FSGS, less than 50% of the food processes will be effaced. So if we look at this is a secondary FSGS where the food processes are still there, but part of the food processes, less than 50%, are effaced. Whereas in case of a primary FSGS, we cannot make out any of the food process. There is just one big mass that is present over the GBM, and this entire line over here, this is the GBM, and on top of that, these food processes are effaced. Here, at least in some areas, we can make out these food process, and in some areas, they are effaced. So obesity associated FSGS, which is the most common type of secondary FSGS which we see. In this, there are two important things that you must remember. First is there will be a perihilar segment of sclerosis, and the second thing is there will be glomerular hypertrophy. How do you define a glomerular hypertrophy? So if the size of the glomerulus, there are three definitions basically. First is if the size is more than 220 micrometers. Second is if the size of the glomerulus is more than 1.7 times that of the age-matched control. Now, both these definitions are quite precise, but the problem is we don't always measure a glomerular size or the diameter, or we don't always have age-matched controls. So a good way of making that out is if the glomerulus is occupying more than 50% of your width of the core of renal biopsy, then we can say that this is a glomerular hypertrophy. This is just a soft So if there is history of obesity, we have a perihilar segmental sclerosis, and we have a glomerular hypertrophy, we can think of an obesity-associated FSGS. Then another thing that can cause a secondary FSGS is this glomerular scarring. Now, this glomerular scarring can occur in various conditions, and there are two main ways in which this secondary glomerular scarring takes place. First is that there is deposition of the mesangium and a segmental sclerosis forms. The other way is that there is a fibrinoid necrosis, and over time it develops into a chronic lesion and it gets sclerosed and it forms a segment of sclerosis, which is what we see very common in case of sometimes an HSP nephritis or in case of an ANCA associated nephritis, where earlier it would have been a fibrinoid necrosis and slowly it has progressed. And finally, what we see in case in a biopsy is a segment of sclerosis. This sort of segment of sclerosis where there is deposition of the there is sclerosis and mesangial deposition, we can see in conditions like diabetes or hypertension, etc. Then we have a collapsing glomerular nephritis. Here, if you look at this picture, this is a normal glomerulus. And here we can see that these capillary loops are collapsed. You cannot make out the lumen of these capillary loops. And if you see these podocytes on top, these podocytes are proliferating. In fact, it is very easy for an untrained eye to confuse this with a crescent. But if you look at these cells, they are plumper and there is no break in the glomerular basement membrane. The best stain to identify a collapsing collapsing GN is a silver stain. So, as we know now, collapsing GN is not a separate entity, but it is a pattern of injury and it is associated with multiple conditions. First is various infections like HIV, parvovirus B19, CMV, and of course, most recently, COVID-19. Second is autoimmune disorders like SLE, mixed connective tissue disorders. Then we have hemophagocytic syndrome or macrophage activating syndrome, various malignancies, drugs, especially pamidronate. Then it can be ApoL1 induced, or lastly, it can always be idiopathic. So this is a study where they have found that almost 41% where they have studied COVID-19 patients, and these are the pathological findings that they have found. First is acute tubular injury, which was the most common in 88%, and 41% of COVID-19 patients presented with collapsing GN. So this is a recent advance that has been seen in case of podocytopathies, and many a times when we are looking at the IF and we are suspecting a minimal change or an FSGS, we know that the IF is going to be negative and we don't tend to pay attention. But if you are seeing these tiny dots which are present just above these capillary loops, this is an IgG stain. So if you're seeing these sort of tiny dots, what has been found is that these dots correlate with an anti-nephrin antibody. So this is the paper which has been published in JASN, and this is the most recent thing that they have found, that minimal change disease and now recently even FSGS could be associated with autoantibodies which are targeting these anti-nephrin, nephrin molecules. So these are the ones which are causing minimal change disease. So if we look over here, they have done this IgG staining and you can see these tiny dots. And if you do a nephrin staining, these small red dots which are present, they are staining the nephrin molecules. And if you merge these two images, there is a co-localization of the green dots and the red dots leading to these yellow dots. So these tiny dots on the IgG, they represent these anti-nephrin antibodies. Thank you. I'll be happy to take any questions. Okay, so thank you so much.
Good afternoon, everyone.
Sorry, start.
Yeah, good afternoon, everyone. Today, I'm Dr. Savan Bopanna. I'm a senior consultant in gastroenterology and hepatology at Action Institute of Liver and Digestive Sciences at Sri Balaji Action Medical Institute, New Delhi. Today, I'll be speaking about interpretation of hepatitis viral markers. So I'll just be giving a brief overview of the hepatitis viruses, followed by their serological profile in various parts of the illnesses. So first, the types of hepatitis viruses. So we have actually 5 important types of hepatotropic viruses, which actually infect the hepatocytes mainly. They do not have any other cells of infection in the body, human body. So the 5 types of hepatitis viruses that are commonly seen in practice are hepatitis A, hepatitis B, hepatitis C, D, and E. So in a healthy liver, when the cells are affected by hepatitis viruses or there's inflammation in the hepatocytes, then it's called as hepatitis. So hepatitis A and E are actually acute hepatitis viruses where they cause self-limiting illnesses and they last for a small time. Whereas hepatitis B and C are chronic illnesses, and these viruses can cause chronic hepatitis, leading to destruction of the liver and eventually liver cirrhosis. So first about hepatitis B. So the structure of hepatitis B is a complex structure. So, and it has several antigens that are present on the hepatitis B virus. And these antigens provide an opportunity for testing, and antibodies to these antigens are used in serological testing for these viruses. Now, the hepatitis B virus, the outer coating is called the surface antigen or the hepatitis B surface protein. The second layer that we see is actually the envelope layer, and this is characterized by the HBE protein or the HBE antigen. And the inner layer, the innermost core of the virus is formed by the core protein or what is called as HBC antigen. And within this core protein core area, we have the main genome of the virus, which is a partially double-stranded DNA. And within this DNA, there is a enzyme, which is the DNA polymerase. So these are the various proteins which make up the structure of the hepatitis B virus. And testing for these various antigens or antibodies to these proteins help us find out the phase of the disease and also help in diagnosis of the disease. So what are the various serological markers of hepatitis B? So as I mentioned, we have HBs antigen, which shows that the person is infected with hepatitis B and can be detected in both an acute hepatitis B infection and also in a chronic infection. We have anti-HBs, which shows that the person has developed immunity to hepatitis B. That is when HBsAg disappears. That is when anti-HBs antibodies arrive. Then these antibodies, if they are present in a person, it shows that the person has developed immunity to hepatitis B. We have the HBe antigen, or what we call as the hepatitis B envelope antigen. And if this is present in a person, it shows that the virus in the body is actively multiplying. And we have anti-HBe or anti-HB envelope protein, which shows that the person's immunity has responded against hepatitis B and the virus is not actively replicating. So when hepatitis B envelope antigen disappears, that's when the anti-HBe antigen is detected in the blood. And the appearance of the anti-HBe or the antibodies to HBe shows that the virus is not actively replicating anymore. Then we have the anti-HB core antibody. This shows that the person has been infected with hepatitis B. Once the person has been infected with hepatitis B, he becomes positive for anti-HB core antibody. And these antibodies, the IgG anti-HB core antibodies, generally remain for life. Then we have HBV DNA, which is measuring the viral load in the body. It measures the copies of the hepatitis B virus DNA in the blood, and the measures of the virus in the bloodstream. And this, if the virus is detected in the bloodstream, it actually means that the virus is actively multiplying within the liver. Now, how does hepatitis B get transmitted? There are 2 important modalities of transmission of hepatitis B. There are several other modalities also, but the 2 important modalities of vertical transmission, basically from mother to child, And the second is horizontal transmission. The second horizontal transmission can be because of infected needles, can be because of sharing of body fluids during blood transfusion and during tattooing and unprotected sexual intercourse. So these are the ways in which the virus get transmitted horizontally. And vertical transmission is generally from mother to child. One of the most common causes of transmission of hepatitis B, especially in India, is horizontal transmission. Whereas in the world, there are several countries where the majority of patients who have hepatitis B because of vertical transmission. That is, the mother has passed on the hepatitis B to the child. But in India, studies have shown the transmission of hepatitis B is mainly by horizontal transmission. Now, outcome of hepatitis B virus infection by age at infection. This is an important thing because the age at which a person gets infected by the hepatitis B virus is important in maintaining the chronicity of the virus. For example, if the virus is there within an infant or within a child, if the virus has infected the liver at infancy or early childhood, the chances of having a chronic infection are high. This is because the immune system of the child or the immune system of the infant is not strong enough to fight off the virus and clear the virus from the liver. So therefore, at birth, the people who are infected with the virus, the chances of chronicity are higher, but the chances of symptomatic infection in these patients are not there. Therefore, somebody in childhood infected with the hepatitis B virus may not show any symptoms at all. Whereas, if you look at if the people who get infected at a later age, the proportion of patients who develop symptoms are higher. This means that if an adult is infected with hepatitis B, the proportion of adults who will show symptoms like jaundice are higher, and the chances of chronicity in adults are lesser. So the later in life that you get infected, the chances of developing a chronic infection are lower, but the chances of developing symptoms are higher. Whereas in children and in infants, the chances of symptoms are very less, and therefore they easily go undetected. And these are the patients in whom chronic infection develops. This is because of a nascent immune system which is unable to clear the virus, especially underdeveloped immune system in children and infants. Now, what are the stages of chronic hepatitis B? So these stages generally are seen in patients or in people who have acquired the virus perinatally and not by vertical transmission. So there are four important stages of chronic hepatitis B. So the first stage is called as the immune tolerance phase. The second phase is called the immune clearance. Third is a low replicative phase, and the fourth is what is called as a reactivation phase. So just to explain, immune tolerance means the body tolerates the replication of the virus. This generally occurs when the immune system is young or immune system is nascent, as I explained, especially in children and infants. So there you will have an actively replicating virus, and therefore the HB antigen will be positive. The HBV DNA copies in the blood will be high. But the immune system is not active, and therefore the ALT levels, that is the aspartate aminotransferase levels in the body, aspartate and alanine aminotransferase levels in the body, they remain low because the hepatocyte destruction is low. This happens because the immune system is not actively attacking the hepatocytes. Then you have normal, and in these patients, you have normal or mild chronic hepatitis. And these patients generally, when they have an immune tolerance phase, they are HBe positive and they have chronic hepatitis. And therefore, these patients are labeled as HBe positive chronic hepatitis. Now, then following the immune tolerance phase, the body starts recognizing the virus and tries to clear the virus from the body. And in these patients, they enter a phase that is known as the immune clearance phase. In the immune clearance phase, the HBe positivity slowly starts turning into HBe negativity. That is, the immune system starts attacking the virus and reduces the viral replication. And therefore, you can see the DNA copies start reducing as the immune clearance phase starts. But when the immune clearance starts, the immune system not only destroys the virus, but also destroys the hepatocytes in the body. And this leads to an increased elevation of ALT and AST. And these are the patients who actually have chronic hepatitis in moderate or severe forms. And these are the patients who would in future go on to develop a chronic liver disease or chronic liver injury and therefore cirrhosis. So when the immune system starts clearing the virus, there is destruction of the hepatocytes, which in turn will lead to liver injury and therefore liver cirrhosis. Once the immune system has actively removed a lot of virus from the body, the virus enters into a stage of low replication, and this is the phase when we start seeing the anti-HB antibodies coming in the blood, which means that the virus has reduced its replication and it's not replicating. And in this phase, because the immune system then also goes into an inactive state, you can see that the ALT levels start normalizing in this phase. And in these patients, you can have some hepatitis and some destruction in the liver because the virus is still replicating at a low levels. And this phase is actually called as the inactive carrier state. So once a patient has entered the inactive carrier state, it just means that the immune system has been able to control the virus, and therefore the chances of liver injury and liver cirrhosis in this group of patients who are in an inactive carrier state is very low, and therefore we generally do not treat patients who have already entered an immune carrier or inactive carrier state. And some of these patients who enter an inactive carrier state later in life may reactivate, the virus may reactivate, which can lead to, again, destruction of hepatocytes. And these are the patients who can then have liver injury and cirrhosis. And these patients are generally HBe negative chronic hepatitis. That's what we call them when they are in the reactivation phase. So these are the various stages in which the chronic hepatitis B occurs in a patient, and a patient goes through these different stages. Now, what are the outcomes of hepatitis B? In an adult HBV infection, around 5% of patients can develop chronic infection. And some of them will enter an inactive carrier state, and some of them will enter a chronic active hepatitis state. In patients who develop chronic hepatitis, up to 15% of patients develop cirrhosis, and up to 5% of these patients develop liver failure or liver cancer. In adult HBV infection, around 95% of the patients clear the virus, and in these patients, HBV infection is considered to be resolved. Now, acute hepatitis B infection with recovery, what is the typical serological course that we see? So once a patient has acute hepatitis B, the infection resolves in 95% of the patient, but in 5% of the patients, there is chronic infection. So as I said, adult HBV infection generally becomes symptomatic, but the chances of chronicity are low, whereas it is completely opposite in childhood HBV infections, where the chances of chronic infection are high, and the chances of infection resolution are low, and therefore when children get infected with hepatitis B, they generally go on to develop silent chronic hepatitis. Now, acute hepatitis B infection with recovery, the typical serological course that we see in adults is they develop symptoms. Then they are initially HB antigen positive, which means that the virus is actively replicating, and soon they will become anti-HBe negative when the virus stops replicating. Now, the HBsAg starts rising as the patient is infected within the first 3 to 4 weeks, and then HBsAg is detectable. This is an adult infection that we're talking about, where generally adults have symptomatic infection, and therefore acute hepatitis B infections are common in adults. Whenever hepatitis B is seen in adults, it's an acute hepatitis B that is presenting with symptoms rather than chronic hepatitis B. And second, you can see that the IgM anti-HBC or the IgM anti-HB core antibody starts rising in the blood early on in the infection and then goes on to settle. The hepatitis B surface antigen continues to rise and then fall and then completely disappears by the end of 6 months. Now, once HBsAg is completely gone from the blood, there is a window period in between before anti-HBs can rise and provide immunity. And this is the window period that's actually important serologically, where HBsAg may be negative, anti-HBs may also be negative. But the way to detect patients in this window period is to test for IgM anti-HBC. And if IgM anti-HBC is positive, then that patient can be labeled as acute hepatitis B. This is especially important in blood banks where there is no HBs in the blood, there is no anti-HBs in the blood, but still the blood that is collected from the donor may be positive for hepatitis B. And it is the core antibody that can tell us whether a person has been infected with hepatitis B. Now, to divide the serological phases of acute hepatitis B, we have the early phase, we have the window phase, and we have something called as a recovery phase. So, what is the combination of serological markers that we see in early phase? In the early phase, we see HBsAg, which is positive. HBe antigen will be positive. This is because the virus is actively replicating in the early phase of acute hepatitis B. The IgM anti-HB core antibody is positive, and the HBV DNA are in high numbers, especially because you can see here the virus is replicating, and therefore the DNA levels in the blood are high. Now, when you enter the window phase, as I mentioned, the window phase is when the hepatitis B surface antigen has completely disappeared. And it is during this window phase, the HBe antigen also has become negative. And the window phase does not show anti-HBs or anti-HBe antibody because they're yet to appear. So these both antigens have disappeared from the blood, but these antibodies have still not appeared. And then in this phase, the way to detect the patients in the window phase is to look at IgM anti-HB core antibody or HBV DNA levels. Now, acute hepatitis B infection in the recovery phase. How do we detect these patients? So in the recovery phase, of course, the antigens for hepatitis B, like surface antigen or envelope antigen, are negative, and anti-HB core antibody is also negative. Now, in the recovery phase, you will see that the IgG anti-HB core antibody is positive, and anti-HBs antibody is positive, and anti-HBe antibody is positive. Now, HBV DNA occurs in very low levels, and this can be either positive or negative. And in recovery phase, sometimes you have very low levels of hepatitis B DNA, and therefore, in the recovery phase, sometimes you may still find HBV DNA positivity. But the important thing to note about the recovery phase after acute hepatitis B is the appearance of the anti-HBs antibody, which makes the patient non-transmitting. That is, the patient with an anti-HBs antibody generally does not transmit the infection to another person. So now coming to chronic hepatitis B, a little about chronic hepatitis B. As I mentioned, that the acute phase lasts for 6 months in hepatitis B, and the chronic phase comes after 6 months. So in the chronic phase, the patients will be positive for HBsAg, but IgM anti-HBc will soon disappear. That is, at the end of 36 weeks or 38 weeks after the initial infection, IgM anti-HBc completely disappears, but total anti-HBc may be positive throughout the infection. And in fact, any person who's ever been infected with hepatitis B will have total anti-HBc positive. So if IgM anti-HB core antibody is negative and total anti-HB core antibody is positive, it means that most of these core antibodies are IgG antibodies. So in a patient with chronic hepatitis B, the patient will be positive for HBsAg, will be positive for total anti-HBc, and may or may not be positive for HBe antigen, because that depends on the phases: immune clearance, immune tolerance, reactivation, and the phases that I earlier described. So it depends on which phase the patient is currently in. But definitely patients with chronic hepatitis B will be positive for HBsAg and total anti-HBc antibodies. Now, to divide serologically, we can divide chronic hepatitis B into the non-replicative phase, the replicative phase, and a replicative pre-core or a core mutant virus phase. So if you want to look at what the replicative phase during chronic hepatitis B, the surface antigen is positive, because surface antigen is positive in all these patients with chronic hepatitis B. And so are IgG anti-HBc antibodies. And therefore, what we generally do is measure the total anti-HBc antibodies, and total anti-HBc antibodies will be positive in any form of chronic hepatitis B. But in the non-replicative phase, HBe antigen will be negative and anti-HBe antibody will be positive. HBV DNA is generally, because it's a non-replicative phase, they are in low levels. And this non-replicative phase is generally what we see in inactive hepatitis B carriers, just like I showed in the previous graph. So when the virus is completely non-replicative and there is no liver injury going on, and the DNA levels are very low in the body, such patients are generally termed as inactive carriers, and we don't need to treat these patients. The chances of liver injury and progression to liver cirrhosis is very low in these patients. Now, when we come to the replicative phase, so of course in chronic hepatitis B, both HBsAg and IgG anti-HB core antibodies will be positive. In a replicative phase in chronic hepatitis B, the IgM will be negative. So if you look at the total anti-HB core antibody, it will still be positive in chronic hepatitis B. But in the replicative phase, you will see that the E antigen is positive and the HBV DNA is high. Now, this replicative phase is generally seen in what we call as the immune tolerant phase. And in the immune tolerant phase, you generally have patients who are immune tolerant, and this generally occurs in young children or in the teenage years. So what about the third form of serological chronic hepatitis B? So the third form that we generally have to treat because there is ongoing liver injury and the low levels of liver injury are there. That is when the E antigen is negative. This happens because there is mutation in the virus. As the virus undergoes immune clearance, the virus starts developing mechanisms to resist the immune system of the body. And one of them is under immune pressure, it loses its E antigen. And this does not mean that the virus is not replicating. Sometimes the loss of E antigen, especially in hepatitis B, in this phase, if there's a pre-core or a core mutant, then the E antigen is negative. Of course, because chronic hepatitis B, you will have HBs and IgG anti-HB core antibody positive, as I mentioned. And in these patients, you will also have anti-HBe antibody positive, but HBV DNA will be on the higher levels. And this HBV DNA is how we come to a conclusion that this E antigen negativity is due to mutation and not due to a replicative phase, because generally when you have HBe antigen negative, you should have HBV DNA at very low levels, because E antigen represents replication, and when it is negative, DNA should be low. Now, serology in an immune person. So if you have a person who's been vaccinated or a person who's had previous infection, how do you differentiate these two? So HBsAg will be negative in both. The anti-HBs antibody will be positive in both if you have taken a vaccine or if you have had an infection before. But the way to differentiate them is to measure the hepatitis B core antigen antibodies, that is IgG anti-HBc or total anti-HBc will be positive in a natural infection, whereas in vaccinated individuals, the core antibody will be negative. So this testing of anti-HB core is very important, especially in areas like India, which is an endemic area for hepatitis B. So if past recovery of HBV infection, that is anti-HBs titers are low, then it is that means that there's past infection, or it can also happen in acute HBV infection during a window period. And it has a significance mainly in organ donation and blood donation, especially to recognize the window period where HBs antigen has disappeared, but anti-HBs antibodies have not yet appeared. So another important test that hepatitis B that we do is DNA quantification, and it's done by real-time PCR. So it helps us to find out when to initiate treatment. So if there's a wild type virus, we initiate treatment when the copies are more than 20,000 international units per ml. Whereas if there is a pre-core mutant, then even more than 2,000 we have to treat. Then we use it to monitor patients, the response to treatment, especially in patients with pre-core mutation. We have to keep doing the DNA levels because that's the only way to find out if the patient is responding to treatment. And we also use DNA to find out reactivation of a patient who's already in a non-replicative phase. Suddenly the patient starts developing symptoms. Then we do a HBV DNA levels to find out if there's reactivation, and also to diagnose patients with HBV infection and fulminant hepatic failure. Now, there are several genotypes of hepatitis B, and in India, the most common genotypes are A and D. The testing for genotypes is not generally done in routine clinical practice, and this is also done by PCR testing. And the significance of genotype actually was earlier, but now because of antiviral drugs that are available, the testing for genotypes is not routinely done. Now, quantification of HBsAg is very routinely done in many labs, and this HBs concentration is basically, it shows the levels of intrahepatic CCC DNA, and the amount of circulating HBsAg is an indirect marker of control of infection and a surrogate marker for the number of infected cells in the body, that is hepatocytes. The HBs titers are higher in immune tolerance phase than in immune clearance phase. And there are various ways of testing this HBS antigen. So how does it help us? It helps us identify the risk of reactivation. Because there are very high levels of HBs AG antigen means that the patient may have high chances of reactivation and going into a replicative phase from a non-replicative phase. Then it helps us to find out the stage of fibrosis, the risk of developing HCC, and also to decide the duration of treatment, especially when patients are in nucleotide analogs. Now, coming quickly to the other hepatitis viruses, we have the hepatitis D virus infection, and this virus is hardly seen in India, and it requires the presence of a concomitant HBV infection, and diagnostic marker for this is IgM anti-HDV. Now, hepatitis C is again a virus which causes chronic hepatitis. So, the acute HCV infection, generally, most patients with hepatitis C infection are progress to chronic hepatitis. So in the early phase of infection, the HCV RNAs are high, but later on they stabilize, and the ALT levels, that is the liver enzyme levels, generally stabilize in chronic hepatitis C. But one thing that will be always positive in patients with chronic hepatitis C is anti-HCV, which will always be present, and HCV RNA will be present in most cases, 90% of the cases. So only 15 to 25% of HCV infected persons clear the virus. Therefore, most patients, that is 75 to 85% of patients who are infected, will develop chronic hepatitis C. The easiest way to diagnose chronic hepatitis C is to do a HCV antibody test and then later confirm it by doing a HCV RNA test, either by PCR or an RNA detection test. And then we do a HCV genotype test where necessary. Now, because of the high mutation rate, that is, the virus inherently has a high mutation rate, and therefore HCV genotypes were initially tested. And HCV genotypes help us to find out the type of therapy, the duration of therapy, and the response to therapy. But due to the new drugs that are available nowadays, genotyping of the virus is generally not necessary these days, because the drugs that are available have a pan-genotypic effect, and they do not influence our treatment decisions anymore. And therefore, you will see that the testing for HCV genotype has slowly been given up now. So IgM, HAV is another virus. Hepatitis A and hepatitis E are viruses which cause acute self-limiting hepatitis most of the times. They're very common in India, and they're transmitted by a fecal-oral route. So the marker of acute hepatitis A is IgM anti-HAV. And when IgM anti-HAV is positive in a patient who has clinical jaundice and lab parameters suggestive of hepatitis, means that they have acute hepatitis A. And if you want to find out if a patient has already developed hepatitis A in the past, then you will test for total anti-HAV antibodies or IgG anti-HAV antibodies. So typical scenario is the initial symptoms are present, the liver enzymes are very high in thousands, and IgM anti-HAV will be positive, which slowly becomes negative over a period of 5 to 6 months. And past infection can be detected by measuring total anti-HAV antibodies in the patient. Now, acute hepatitis E is very common, and it's one of the most common causes of hepatitis in India. And hepatitis E virus is detected by testing antibodies, that is IgM antibodies to hepatitis E virus. And a typical serological course looks like this. When the patient has symptoms, the enzymes are very high, the liver enzymes are very high. And the way of diagnosing acute hepatitis E is to measure the IgM anti-HEV levels. And this is what we clinically use to detect a person who has acute hepatitis E infection, especially in a person who presents with symptoms like jaundice. So that is it, an overview of hepatitis, acute hepatitis and chronic hepatitis. Now, if you have any questions, I'll be glad to take it. Thank you. Okay, then. Thank you. I think my time is up. I'll now be taking leave. Thank you for the opportunity. Thank you.
Good afternoon, everybody. Can I share my slides, please? Hello.
Yes, sir.
Yes, can I start here?
Yes, sir. Yes.
So can I have a slide? Can I have my first slide, title slide? My title slide, please. First slide. Yes, this is my presentation. Okay. Am I audible? Can I start? Can I start, please?
Yes, sir. Start.
Okay. Good afternoon, everybody. I am Dr. G.S. Lamba. I am Chief of Gastroenterology and Hepatology at Action Institute of Liver and Digestive Diseases, Sri Balaji Action Medical Institute, Paschim Yard, New Delhi. So I will be talking today about a disease which is very, very common nowadays. In today's time, it is one of the most commonest diseases. It has taken over all other etiologies of chronic liver disease and is now the commonest cause for chronic liver disease as well as cirrhosis the world over. And it is so common that I think the physicians or the clinicians or the diagnostic people who will be there in the audience, they will agree that uh, a condition, fatty liver, is probably seen every day. Every day they must be coming across patients who have got a fatty liver, and hardly a day passes when they don't see such a patient. So this is what it is. Today we are talking about fatty liver, a disease which is very common these days. And I think it would not be a wrong statement to say that there is a global epidemic of fatty liver all over the world. So let's see how we approach these patients. How do we really go about working before we start treatment and before how do we work up these patients? And that is my topic today, approach to a patient with fatty liver. But before I go to actually how to approach these patients, I would like to tell you a little bit about the background of this disease, the pathophysiology, the epidemiology, because that probably will help us in understanding how to approach these patients. So coming firstly to my first slide. The slides are not moving, please. Yeah. Now, this is a typical representation of a patient, who can have a fatty liver. You see a middle-aged man who's definitely obese and who's got a very fat belly. And this is the patient who's probably has diabetes also, and probably has dyslipidemia also. And this is the patient who is the most likely to have a fatty liver. Now, as you know, that this patient typically represents a patient of what we call as metabolic syndrome, and this patient is actually a walking time bomb. Although he may seem very happy, but he's a walking time bomb who can explode anytime. He can explode from the cardiac side. He can explode with the CAVA. He can explode on the diabetic side. And now we know that this patient can also explode from the liver side. So the liver involvement in this overall metabolic syndrome is probably as serious as other involvements. Next slide, please. Now, coming first to the definition of fatty liver. The definition is very simple. It is basically an intracytoplasmic accumulation of triglycerides in vesicular form in greater than equal to 5% of hepatocytes. So if 5% of hepatocytes have got fat in it, accumulated in it, it's a fatty liver. Or the alternative way to put it is that fat content of the liver is about 5% of the total weight of the liver. So this is how we define fatty liver. Now, fatty liver, next slide. It can be caused either by alcohol or it can be a non-alcoholic fatty liver disease. So these are the two broad subsets of fatty liver disease, of which I would be talking about the non-alcoholic fatty liver disease, because alcohol-induced fatty liver disease is a separate topic altogether. Next. So this non-alcoholic fatty liver disease, basically it is a disease in which there is, as the definition says, there is fat in the hepatocytes. And the histology is very similar to what we get in an alcoholic liver disease patient. But this patient does not take alcohol. So that's why the word non-alcoholic fatty liver disease was there initially. It is still continuing, but it is going to change very soon, because a connotation alcoholic, it has got its own stigmatas. So nowadays, there has been an international working committee which has changed the nomenclature of this disease. But for the sake of continuity, and because all the literature which we have is on non-alcoholic, with this term non-alcoholic fatty liver disease, in this particular talk, I'll be using this term. But very soon, probably the name is going to change to metabolic associated fatty liver disease. Next. So now you have to understand this fatty liver disease is a big set, it's a huge set which includes different patients with different severity of the disease. And this severity is basically based on what their liver histology shows. So a fatty liver patient can be a patient who has simple steatosis on histology, which is, the pure form of fatty liver disease, in which there are only lipid droplets. But gradually, because of the presence of this lipid, there will be inflammation. And then it will become a combination of lipid plus inflammation, which we call as steatohepatitis or non-alcoholic steatohepatitis or NASH. Then gradually, this inflammation will lead to fibrosis, when the combination will become of steatohepatitis plus fibrosis. And lastly, this fibrosis will lead to collapse of the liver architecture, and we'll get a full-blown cirrhosis, when we will get what we call nowadays as NASH-related cirrhosis. So all the four severity stages come in this overall term non-alcoholic fatty liver disease. Next. Now, why these severity stages are important, because we know as the patient progresses from fatty liver to steatohepatitis to fibrosis to cirrhosis, his morbidity and mortality obviously increases. So that's important. That's why it is important to know at which particular stage a particular patient is, because his morbidity and mortality will depend on that. Next. Now, if we come to the epidemiology of NAFLD, this is a disease, which has now, as I told, become the most common cause of chronic liver disease in many countries across the world. It is not only in Asia, but Europe, North America, Middle East, everywhere. everywhere it is becoming the commonest cause of liver disease, especially because hepatitis B and C, and now they have been controlled to a large extent. So now this has become the major cause of liver disease all over the world. And next, next slide, please. Yeah. One of the very basic tenet of this disease is that NAFLD is associated with metabolic syndrome. Now, you all know what is a metabolic syndrome. It is basically a disease syndrome where you have obesity, hypertriglyceridemia, hypertension, diabetes or impaired GGT, and dyslipidemia in form of low HDL or increase in cholesterol or triglycerides. So this is a metabolic syndrome, and there is a strong association of NAFLD and metabolic syndrome. So 90% of NAFLD patients will have at least one feature of this metabolic syndrome. Either they will be obese, or they'll have dyslipidemia, or they'll have hypertension, or they'll have impaired GTD. Something or the other of the metabolic syndrome would be there. Next. 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 So now probably, we can confidently say that NAFLD is also a part of this metabolic syndrome, and it is the hepatic manifestation of this insulin-resistant syndrome or metabolic syndrome, which we call. So we knew its cardiovascular components, the diabetic component of metabolic syndrome we knew, and probably liver is the fatty liver is the liver component of this syndrome. Next. Now coming to some figures to show what is the association. 80% of NAFLD patients have increased BMI. About 30 to 40% are obese. 50% of these NAFLD patients will show insulin resistance on investigations. 80% of them will show hyperlipidemia. And 30 to 60% have got arterial hypertension. So this strong association of components of metabolic syndrome with NAFLD, they are there, they are universal, and they are seen all throughout the world. The association with diabetes is also very strong. Next slide, please. And if you see the figures, about 40 to 70% of diabetes patients will have a fatty liver. 20 to, or in putting in the other way, 20 to 30% of fatty liver patients will have underlying diabetes. And it has been seen that diabetic patients who have fatty liver, they have a higher cardiovascular morbidity as compared to patients who do not have fatty liver. So there's a strong association between fatty liver and diabetes also. Next. Next slide. Coming to a very interesting entity which is known as lean NAFLD. Now, as you have seen, that majority of the patients, that I already said, about 80% of the patients of NAFLD will be overweight, and about 50% of them may be probably obese. But then there is still a subgroup of patients who are very lean and thin, but who have fatty liver. So these patients have been called as patients having a lean NAFLD. This type of, these type of patients are more common in our Asian population as compared to a Western population, where the increased body weight or obesity is even more common. But even in Asia, if we see that some of these patients will not be overweight or obese as per, according to the BMI category or the weight per se, but they may be metabolic obese. And by metabolic obese, I mean that they may be carrying central obesity. The overall weight may not be high, but they may be obese from the mid body the mid body circumference would be more, or they will be having an insulin resistance, although the weight has not increased. So we should also keep this in mind that not all the patients of fatty liver are going to be fat. There is a subset which is known as lean NAFLD also. Next slide. Now, is the central visceral obesity a risk factor for NAFLD? Yes, it is. Next. It definitely is. Next slide. Visceral obesity has got its own mechanism by which it causes NAFLD. So it's visceral obesity, which is more important, or the central obesity, which is more important as compared to the overall weight of the patient if he has to develop a fatty liver. Next. A very, next slide. A very, next slide, please. Next slide. Can we go on to next slide, please? Yeah. A very, I would say alarming thing about NAFLD is what we called as pediatric NAFLD. You see, the age is no bar for having a fatty liver. And even small children nowadays, we are seeing a lot of, children carrying an ultrasound report where they have fatty liver. The prevalence is pretty high, 2 to 17% in different studies. And in adolescents, it becomes even higher with the incidence ranging from 10 to 77%. This is something I think which is very alarming, because these are the patients who are going to live pretty long, and during their lifespan, this fatty liver can transform into a steatohepatitis or later on to fibrosis or cirrhosis. And I think it is quite important to intervene in these patients from very young to protect their liver. So these are some alarming figures of pediatric NAFLD. Next. Next slide. Yeah. Now, I will not go into the detail of pathogenesis of NAFLD because that's not my talk today. But the main thing to remember is that insulin resistance probably is the key component in the pathophysiology. Things start from there. And this insulin resistance in the muscle results in hyperglycemia, and due to inability of the cells to utilize glucose. In the adipose tissue, this insulin resistance leads to excessive release of free fatty acids, which are reaching the liver and thereby causing a fatty liver. And in the liver itself, this insulin resistance causes an increased rate of de novo lipogenesis and a reduced rate of beta oxidation by the hepatocytes. And all these factors then lead to development of fatty liver disease. So I think this is a just one slide pathogenesis, although we can have a full topic on pathogenesis of NAFLD, but this is a one slide representation of pathogenesis of NAFLD. Next. Next slide. Is it a genetic disease? Yes, we see familial clustering, and probably in some of these families, there may be obesity, which is running in the family. There may be hypertriglyceridemia, which is running in the family. Cholesterol, hypercholesteremia runs in the families. So there is some genetic component, but obviously the environment insults are also important. A person who leads a very sedentary lifestyle, is not careful about the diet, puts on a lot of weight, this patient is likely to develop NAFLD, whether he is genetically predisposed or not. But in a family, does a positive family history influence the severity? This we don't know, but this is an important concept. Suppose we have one person in the family who has a lot of morbidity and probably mortality due to fatty liver disease. It is important to caution the other patient, but we are not, we don't have too much data on this. Next. Next slide. Now, coming to the natural history of NAFLD, you see it's a slow disease. From a normal liver, if you get a fatty liver, it takes about 10 to 20 years to progress from fatty liver to NAFL to steatohepatitis, and then to fibrosis, and finally to cirrhosis. So it's a slow growing disease. Slowly from fatty liver, one develops steatohepatitis, and from there one develops fibrosis and cirrhosis. The interval is about 10 to 20 years. And once a person develops cirrhosis, then like any other cirrhosis, in 3 to 6 years' time, he is going to decompensate. And once he is decompensated, then in 1 to 2 years, either the patient will not survive due to complications of cirrhosis, or he may develop a hepatocellular carcinoma and eventually he may die because of it. So fatty liver is not all that benign, but I would not scare everybody. It's not benign, but then it is a slow growing process also. It's not a very rapid overnight disease which can cause any catastrophe. Next slide. Next slide. You can skip this. Next slide. Next slide. Okay. Now coming to the etiology of fatty liver, as we have seen that majority of them are going to be associated with metabolic syndrome. majority of the patients, more than 80 to 90% of the patients are going to have a fatty liver. If you see, 80 to 90% of them will be part of the metabolic syndrome. But there can be other causes of fat accumulating in the liver. So technically, then there can be other etiological causes for NFLD also. And surprisingly, the other causes are malnutrition and starvation. So too much of food is bad, and too little of food is also bad, because it can lead to the similar consequences in the liver. So even a malnourished or a starved person can develop a fatty liver disease. Next. The other causes of fatty liver as such can be, next slide, are drugs. There are certain drugs which as a side effect can cause fatty liver. And the important in the list is the cytotoxic drugs, steroids, estrogens, amiodarone, tamoxifen, tetracycline, hydrolyzine. Why I'm telling you this is basically, once we talk about the approach, which we are going to talk very soon, when we take the history of these patients, it's important to find out if he's on any of these drugs. Next. Next slide. Now, there are some other miscellaneous causes of fatty liver. Total parenteral nutrition, that's one of the causes of fatty liver. Small gut bacterial overgrowth is associated with fatty liver. Severe anemia is associated with fatty liver. Fatty liver can be seen in Wilson disease. And a high fructose intake or too much of intake of aerated drinks has also been linked to fatty liver. Next. Now, coming to the symptomatology of NFLD. Now, majority of the patients, are asymptomatic. They do not have, they will be having a fatty liver, but there will be no symptoms because of that. And even if they have some symptoms, the symptoms are very non-specific. For example, a pain in the right hypochondrium, some vague fatigue or malaise, no specific symptoms which can, by symptomatology, we can pick that this patient has got a fatty liver. So then how do we encounter a patient of fatty liver? Let's see that. Three ways, because symptoms are not there. So how does the patient come to us? Next slide. There are three ways, in which we will encounter a patient of fatty liver. One, patient got an ultrasound done. This is a very common scenario. A patient gets an ultrasound done for some cause, and the ultrasound shows fatty liver. So this is the commonest way when patient, and then the patient comes to us as physicians or gastroenterologists that I have got a fatty liver, know what to do. Second is, during a clinical examination, you pick up a hepatomegaly, and then in further workup of hepatomegaly, one finds that the patient has got fatty liver. And third very common cause these days is then patient got a routine blood biochemistry done as a part of an annual health checkup or a pre-employment health checkup, and they were raised transaminases. And from there, the story started, and from further investigation of transaminases, it was found out that probably this patient has got a fatty liver. So these are the three common ways in which patient will come to us. Next. So now, actually coming to the approach to these patients, once this pathophysiology and these associations are clear, the approach becomes very simple. And there are three main things which we need to do when the patient comes with a report of fatty liver. First of all, we have to find out the cause or the basically the associated comorbidities, which I told you are very common in these patients. So we have to look at that. Second important thing for prognosis and treatment of patient is to assess the severity of liver damage, whether this patient is just a bland fatty liver, or he's having inflammation in the liver, or he's full-blown cirrhosis. So we need to know that. And third, obviously, is to start the treatment, which is not the topic today. Next. Next slide. So starting to work up these patients, first of all, the history. We have to take a history of diabetes, hypertensias, hypothyroidism, hypertension. As I told you, some of the common drugs cause fatty liver. So take a drug history, watch our drugs patients is on steroids, is he on estrogen hormones. We have to look at that. Is there any past history of surgery? That is important. If, because many of these, these days patients who undergo bariatric surgery and all, they've got a fatty liver. So we have to ask the history about that. Food going into the dietary habits is also important, because that will help us in counseling our patients later on, and intervening in them with therapeutic measures. Next. Next slide. Coming to clinical examination, there's nothing much except that we have to look for obesity, and in the, if the patient comes in an advanced stage, then obviously we will have a look for any signs of chronic liver disease, stigmata of chronic liver like ascites, spider angiomas, splenomegaly, palmararrhythmia, and the others. Next. So after history and exam, next slide. Next slide, please. Now we start investigating these patients. When we have taken the history and the clinical examination, we start investigations. Now, investigations are basically, we can divide the investigations in three important categories. One is for diagnosis, which, as I told you, most of the time would already have been done. The patient would have the ultrasound report. But yes, for diagnosis, we need investigations. Second is to find out the etiology. And third is for assessing the severity. So I think this makes the approach very simple, that you take when a patient's you take a detailed clinical history and and do the clinical examination, and then you start investigating these patients, and the investigations can be divided into diagnosis, etiology, and assessing the severity types. But now coming first to the diagnosing part. Next slide. Now, the most important thing, the most important investigation for diagnosis is, as you know, is ultrasound. Either the patient would already have it, will come with that, or you have to get if you pick up a hepatomegaly, you have to get an ultrasound done. This is very simple, cheap, easily available investigation. And in this can very easily pick up fatty liver. And usually the features on ultrasound are presence of a bright liver, increased echo texture compared to kidneys, and vascular blurring. So these are the features which, tell a clinician, tell a radiologist that probably this patient has a fatty liver. Next slide. And next slide, please. Generally, the radiologists try to classify these patients into mild, severe, or focal, or grade 1, grade 2, grade 3 fatty liver, depending on the, the extent of hepatic involvement which they can see on the ultrasound. Next. Next. Now, although ultrasound is a very good modality, it is very cheap and easily available modality, but there are certain limitations on ultrasound. One important limitation is that ultrasound has got a sensitivity that it can pick up fatty liver when more than 30% of the liver is replaced by fat. And we know by definitions, if it's more than 5%, it's a fatty liver. So these initial mild cases, these are some things which which is something which can be missed by ultrasound. The sensitivity is not so good in the early stages of fatty liver, but as the fat advances, then obviously it becomes easy for the ultrasonologist to pick up fatty liver. Second important limitation of ultrasound is that it can pick up a fatty liver, but it cannot differentiate whether this patient has got a underlying, along with fatty liver, a steatohepatitis or fibrosis. That is something which ultrasound cannot pick. Obviously, if it has become advanced to the stage of cirrhosis, then obviously the changes can be picked up. But changes of NASH and fibrosis cannot be picked up. And because of this limitations of ultrasound, the other modalities were also tried to, in this condition. Next slide. And, CT scan, MRI, spectroscopy, all these were, studied in this disease. They are all, one slide before. Can we go to the previous slide, please? Previous slide. Previous slide. Okay. Basically, yeah. You see, the CT scan, MRI spectroscopy, these have been studied in fatty liver patients. Although CT scan and MRI, they increase the sensitivity, and the best is MRI spectroscopy because it increases the sensitivity to pick up a fatty liver and to give, a better quantification of how much of liver is involved. But again, that limitation of not being able to differentiate pure fatty liver from steatohepatitis and early fibrosis is something which even these investigations were not able to do. So unfortunately, by radiology, we can pick up fatty liver, but we cannot pick up categorize these patients into further subgroup or pick up the severity of fatty liver is not possible with most of the radiological imaging studies. Next. Next. So next important thing in workup of this patient is obviously to get a LFT, because the fatty liver, we want to know what are the liver function tests. And in fatty liver, about 50% of the patients who have steatosis, they will have some slight subtle abnormalities in the liver, function test profiles. But if the stage has progressed to NASH, then almost 80% of the patients will have got some abnormality of the liver function test. And the most common abnormality which we see is that AST and ALT, they are raised. They may be raised up to 4 to 5 times of normal. They're not raised as high as you see in viral hepatitis, but about 1 to 4 times of normal. You will say raised ALT and AST. Initially, ALT is more than AST, and but as the disease progresses and patient goes into cirrhosis or advanced cirrhosis, then probably the ratio will reserve and AST will be more than ALT. Otherwise, initially the ALT is more than AST. The other parameters of liver functions like bilirubin, albumin, prothrombin time, these remain normal till very late in the disease when the patient has become cirrhotic. Otherwise, in the early stages, this is not going to help us and they are going to remain normal. Next slide. Next, as I said, once we have diagnosed that patient has got fatty liver on ultrasound, and then we have done his LFTs, the next important step is to find out the etiology behind this fatty liver. As I said, that the most important thing is to look for the various components of metabolic syndrome in these patients, and for that we will get a blood sugar done, fasting PP, a hemoglobin A1C should be done, a lipid profile should be done, as because I said about 70 to 80% of the patients might have dyslipidemia along with fatty liver. Serum insulin levels have to be done. Then thyroid, as I told you, is another condition in which fatty liver can occur. So it's good to screen for thyroid, and thyroid function tests should be done. And I think this is an important point to screen these patients for HBS and anti-HCV also, because sometimes, especially hepatitis C, can initially have a histology in which there is a lot of fatty liver, So sometimes early manifestation of these diseases could be fatty liver. And so it is good to screen for HBS, AG, and anti-HCV in these patients, especially if they have raised transaminases, because both the diseases can coexist also. So in the investigations after LFT, we get a blood sugar done, lipid profile, thyroid profile, serum insulin, and hepatitis markers B and C for hepatitis B and C. Next. Next. Now, the important thing comes, once we have diagnosed, and then we want to know the severity. And as we have seen that none of the previous investigations were able to tell us what is the severity of the disease, how much is the liver damage, which is our prime concern. That is probably not, clearly shown by the rest of the investigation. So for which we have to move on to liver biopsy, and liver biopsy is the gold standard for picking up the severity. Next. Next. And liver biopsy, you see the various stages of fatty liver can be seen: steatosis, hepatocyte ballooning, lobular inflammation, and fibrosis, depending on which stage the patient is, that we can find out. Next. Next. These are some slides which I think most of the pathologists in the audience would be familiar. This shows steatosis. Next. Next. The classical hepatocyte ballooning, which we see because of fat, early fibrosis. Next. And then advanced cirrhosis. This is the kind of histology which we would see depending on the stage of the patients. Now, as we say that liver biopsy is the gold standard for diagnosing the severity of this disease, but the problem, there are a lot of limitations with liver biopsy also. Number one, it examines only a very small 1:50,000 thousand specimen of the liver. It is an invasive investigation which has got its own complications. Even more mortality has been associated with liver biopsy due to complications. So it's an invasive test. And thirdly and lastly, the disease distribution in fatty liver may be patchy, and we are taking a very small sample. So fatty liver can be missed, or its severity can be missed if the disease is patchy. So liver biopsy has its got own limitations. So there was always an interest that we need something. There was there was this short gap that we need something that which can tell us about this fibrosis, and without the help of without the help of biopsy. If we can do something non-invasive and get to know. So there were certain, there was research on this and two things came up. Next, two non-invasive ways of finding out the severity of liver disease. And these were the biomarkers and fibroscan. Now coming to biomarkers are basically, blood, markers which may indicate underlying inflammation, which may be, which may tell us that there is cell apoptosis which is going down or oxidative stress which is going on, which may also indirectly tell us that there is fibrosis which is going on in the body. And obviously fibroscan I'll be talking about in 2 minutes. Coming first to biomarkers. We have biomarkers for inflammation. For example, a decrease adiponectin or increase ECRP or increase IL-6. But as you know, these are all very non-specific markers and they may be high in any disease, any inflammatory disease. These will become high or low. So whether this are because of fatty liver is very difficult to say. Next. Then we have biomarkers for oxidative stress, like increased glutathione, increased malondialdehyde, increased NO. Again, in a fatty liver patient, if these are high, indirect evidence that there's some oxidative stress going on probably in the liver, but again, not too sensitive, not too specific. Next. Then we have biomarkers for fibrosis like hyaluronic acid, laminin, and ferritin. These can also guide us. If they are high, then we know that some amount of fibrosis is going on somewhere in the body. So this can help us in making some sort of prediction. As you've seen that most of these biomarkers in an individual capacity are not going to help us because they are so non-specific. The sensitivity we don't know, and it is very difficult to on the basis of a single biomarker say that what is the stage of this patient. So what people tried was they took do a combination of 3 to 4 or 5, 6 biomarkers and they did research and then they came out with certain scores based on this group of biomarkers, and that probably has got more accuracy in predicting that which stage the patient is. It can pick up fibrosis and all. If we have 5, 6 biomarkers and a composite score based on that, and this you will see in the next slide. Next, there are certain scores which are available next based on these biomarker combinations like BART score, ELF score, or a fibrotest score. These are a fibrotest score is available in our country also, and we can get it done. And based on the biochemical markers in the blood, they can tell us to a reasonable level of accuracy that this patient is probably having significant fibrosis or not in the body. So another important innovation I said was FibroScan, which is a very beautiful tool these days, a very easily available and a good tool. It is based on transient elastography, which uses ultrasound to quantify liver stiffness and estimate fibrosis. Next. It's a very simple portable machine, although very expensive, but otherwise very user-friendly and a portable machine. Next. And it is done just the way patient gets ultrasound done. And this is one of the typical reports of what you will see, that it tells us about the amount of fat with the CAP values, and more importantly, the E value, which tells us the amount of fibrosis. Any E value above 8 is significant. Anything between 8 to 12 shows that there's significant amount of fibrosis. And beyond 12, if this value it is a very good predictor of telling us that probably this patient has got cirrhosis. Next. So the advantages of FibroScan are that it is non-invasive. It can assess a large area of liver, unlike biopsy, and it can allow multiple. It's non-invasive, so it can allow us multiple readings after intervention, before treatment, after treatment. But the disadvantage of FibroScan is that the readings can be falsely high in very obese patients. It's very difficult to get a good FibroScan in those patients, and many of these patients are going to be very obese. Secondly, inflammation, if it is there in the liver due to any other cause, that can be an artifact. And cost is now reasonably not that high because of increased availability, but it's still, for some people it may be high. So these are some of the limitations of FibroScan. Otherwise, very good non-invasive tool in screening these patients. Next. Next. So should it we get in all patients? I think gradually this would be the scenario when the cost is not so deterrent. So, but till then, yes, special group patients definitely. For example, patients who are morbidly obese, patients who have got signs of liver cell failure, cirrhosis, patients who have got competitive etiologies, we are confused whether, along with fatty liver, they are also HbS positive, anti-HCV positive. The two etiologies is very important, always important to know whether the patient has got significant liver damage or not. And then obviously to monitor therapy and response we have started. Then these are the patients where we should get a fibroscan done. Next. Next. So just summarizing, if the approach to NAFLD patient, if a patient of NAFLD comes to us, if a patient comes to us in which we are suspecting NAFLD, then we have to take a detailed history and clinical examination. We have to investigate him, confirm his fatty liver on ultrasound. If required, not so sure on ultrasound, then we can go in for CT scan or MRI, and then investigate him for his metabolic risk factors, and this includes blood sugar, fasting and PP, lipid profile. And then further, we have to look for any competing etiologies like HbS, Ag, anti-HCV, thyroid, and obviously serum insulin in these patients can be tested. Then these patients can be subjected to fibroscan to know the severity of their liver disease. And liver biopsy obviously is not something which we can do in routine, only in special group patient where we need to know the definite diagnosis or definite evidence of cirrhosis has to be seen. So I think by this, you see the approach to NAFLD is not all that difficult. If we know the background and the pathophysiology, a systematic approach, we can work up these patients, and then we can take them for interventions and treatments and lifestyle modification, which obviously is a separate topic which we are not discussing these days. Thank you. So I think that with this I end my talk, and if there are any questions, I'd be happy to take. Any questions, organizers?
No, sir.
Okay, so I think thank you everybody for your patient listening. Thank you, and thank you Melap team for giving me this opportunity today. Thank you.